some of your faces at least. If possible, could you turn on your videos? It's been a long time I saw you all, even previous batch students. Yes, new intake. Yes, hi Jibins, Archana.
Hi.
Hi, how are you all? Doing great?
Fine.
Bit apprehensive? Yeah. Okay. Hi, Thelma. Fine. So it's nice to know, and yeah, you all are here. There are many joining in, so we'll wait for a few minutes for them also to join. Okay, you would be a little, in the sense, you would have got a brief idea on NCLEX, isn't it? So what's NCLEX and how it's going to be? So what thoughts you are having in? Like, are you thinking it's going to be really hard? Yes?
Yes.
No answer? In the sense, it's not that hard. I mean, yeah, so you all are nurses, and it's very clear that you know something, isn't it? So somebody's mic is on. Okay, so I'll put you on mute. So when you want to answer, you can unmute because background noise is disturbing others as well. Fine. Okay. See, you all know, but here NCLEX, in the sense like you all know many aspects, isn't it? So on nursing, the aspects of nursing, the disease conditions, the signs and symptoms, of course, even the management. But NCLEX focuses on how you apply the aspects that you already know. Okay, so a client who is in front of you with chest pain, so there are many aspects he could actually be telling you, and there could be many things which you have to do supposedly for him. Okay, but depending upon the scenario, how you do or how you apply matters here for NCLEX. Okay, for example, if he's saying that I am having pain which began from today morning, so he's only complaining. Okay, in that case, what should be your action? If there is a question, you should assess your client first. So that goes as your first action, initial action. Okay, so suppose in the same scenario, whereas the question says also adds something else, saying that his saturation is 92, then what's your priority? In that case, your priority will be something else depending upon the options. Okay, the scenarios may remain the same. So whereas the questions that will be put to you differs here, and based on the scenarios, you will have to apply what is right to that particular condition or to that particular situation. Okay, so this is how NCLEX actually works. So you should be actually trying to understand the different scenarios and how in those scenarios the questions are given, in the sense at the end. So there is one statement, what would be the best action, or what's the initial action, what's the priority, or which is, I mean, so some negative focused questions or negative query questions are also there. Fine. So which is the, I mean, so which intervention you should be actually questioning. Okay, so those kind of situations will be there, or those kind of stems would be given. So you should understand the scenario first, and for that scenario, what they are asking you to answer, and based on the options, how you will be selecting. Okay, so all the options are usually correct for NCLEX. Okay, so it's not that only one is right and others are wrong. So NCLEX focuses on best options. Out of all things that you are going to do, what would be the best thing that you can do for this situation, so that will actually benefit your client. Okay, so NCLEX works in this pattern. So as you practice, in order to get into the track of understanding the questions, you will have to practice a lot. Okay, you need to practice a lot. So to succeed in NCLEX, it's only through continuous preparation. You need to prepare a lot. Okay, you need to learn through mistakes, in the sense when you go wrong in answers, you know, so why you went wrong, you need to understand that. Okay, so understanding the concepts, applying from the mistakes. Okay, so or whatever you have learned by doing mistakes, so those aspects you should learn to apply. Fine. Okay, so and only if you know certain aspects, it's not enough. Like especially through classes and all, you will come to know many things. Okay, but only knowing these information is not enough. Applying that, whatever you have learned, is necessary to succeed in this NCLEX exam. Okay, so you have to practice a lot. I'm saying this from the beginning itself. Even old intakes also know, the previous intakes also know. I keep saying this from the beginning. Every day, a minimum of, those who are really busy, you know, so a minimum of 20 questions at least you have to do. But at least maximum, in the sense those who are free, those who do not have any other work commitments and all, you can start with 50 questions daily, at least 75 you need to complete. Okay, so preparing through questions is the key for success in this exam. You need to understand. Okay, so that's really important. Fine. Don't feel, you may sometimes feel that you are inadequate and you are not having the essential skill and all, but believe in yourself. So what you, I mean, so you do know, you do not know your potential actually. Okay, so that is our deepest fear. So we feel that we are inadequate sometimes, isn't it? So but we actually don't know our maximum potential. So apply, give your complete potential, and you will find success. Okay, but hard work is must. Fine. So let me start with, I think others have also joined here for the today's lecture, and let me start with today's session. Yes. Okay. So the initial part of today's discussion would be on nutrition. So this is really easy, nutrition. Okay. So after that, we would be starting with gastrointestinal disorders. Fine. So nutrition, in the sense, there are certain questions that will focus on easy kind of questions, because NCLEX has, initially there will be easier questions, and after that, based on how you answer the easier questions, you get the next kind of questions, isn't it? So now nutrition is one of the easiest topics, from where you get questions basically under the client need, basic care and comfort. Okay, so that is the client need or the client area of NCLEX where nutrition is focused on. Fine. So under nutrition, so the key concepts are assessing a person who is having nutritional problems, and the diet you will be starting with clients with specific conditions. Okay, so these are the areas wherein the nutrition focuses. Find the questions in NCLEX focuses on nutrition. So to begin with, what is nutrition? Nutrition in the sense, or a healthy diet. What's healthy diet? Healthy diet in the sense that consists of variety of nutrients, okay, which is less in salt, sugar, and saturated fat, where you are having, in the sense, in nutrition, the most important one is BMI and weight management. Okay, so under BMI, may I know, so below what level do you say that a client is underweight? What's the normal BMI? Yes, you can put your answers in the chat box, or also you can unmute and answer. What's the normal BMI? Yes? No answer? Normal BMI should be?
It's 18 to 20.
18 is less. Okay, so it's
20 to 24, ma'am.
19 to 24. Okay, 19 to 24 is the normal BMI. Below 19 is considered as underweight. Okay, so about 24, in the sense it's overweight, up to 27, but about 27 can be considered as obese. Fine. So weight in kg divided by height in meters square. So this is the formula that you apply to know the BMI. Weight in kilograms divided by height in meters square. Fine. So this is very important. That is, the overall nutritional indicator is albumin. So albumin, okay. So albumin in the sense, albumin, pre-albumin, so which is the precursor of albumin. So these are the, here, what does this albumin do? What's the basic role of albumin? Any idea? So why it is called as the nutritional indicator? What's the significance? Yes. Yeah, keep answering. We all are here to learn. If you go wrong, it's not at all a problem. Yes.
Decreased albumin can lead to edema.
Decreased albumin can lead to edema. Okay, fine, that's right. But my question is, why albumin is one of the main indicator for nutritional status? Yes.
Fluid into blood. Okay.
Because it helps in breakdown of food.
Sorry, it helps in the absorption of food. In the sense, albumin is a kind of protein, isn't it? So the albumin, what does that indicate? Measuring albumin gives us an indication of protein in your blood. Okay, so now, so this is one of the main indicators. Like if you know the protein in your blood, so you know that how well a person, whether he is nourished or not, because protein is one of the important, component of nutrition. Okay, and of course, if albumin is fine, so that indicates our liver is healthy, because liver is basically responsible for metabolizing the food. Okay, so metabolism, so food metabolism basically happens when liver is there in its healthiest state, and albumin gives us an indication of an overall health status of our liver, or the condition of our liver. Okay, so that's why, so albumin is one of the overall indicators for nutritional level. Okay, so even pre-albumin also. Fine. So moving to the next, you should learn the normal albumin value. Okay, so 3.5 to 4.5.4. See, please, a new intake students, make sure that you are having a notepad or you are having a book wherein you write down every piece of information which is important. See, please don't write whatever you already know. Okay, so you know the importance of nutrition and all those things. Okay, so the initial part, no need to write. So if you do not know, if you did not knew the what was that the main overall indicator of nutrition, so then you should write that. You need to write the normal value of albumin. Okay, so in which conditions the albumin can go high, and also in which conditions the albumin can go low. So you need to write down these information. Okay, so whichever you do not know, so that should be there in your lecture notes. Fine. So there are many things which are not in the slides, so we may bring it during explanation. So you need to write down those points. Okay, and while making notes of your own, make sure that you use different pens, different colored pens. Okay, so that will make your notes attractive and beautiful. As much as possible, write neatly. Okay, so that's very important, because at the end, before exam, the notebook is the only thing that you will rely to revise. Okay, yeah. So, oh, somebody's vessels are falling down, I think so. You are, could be you are in kitchen, dining. Anyways, I'm going to mute your mic. Okay, fine. Okay, so hope you have written down the normal value, 3.4 to 5.5 grams per DL. So what are the conditions where the level of albumin would be high? So in infections, burns, stress, okay, and low albumin levels are seen in liver diseases mainly. Okay, I'll come to explanation of these albumin related liver function and all in detail. So in the later part of today's session, so that is while we discuss gastrointestinal system, I'll be explaining about all those aspects. Okay, because we are going to discuss something on liver. So there I will be explaining about this albumin and all. Okay, yeah. So moving next, please note down the serum pre-albumin concentration also, because pre-albumin is also responsible for maintaining the nutritional, so this is an indicator of nutritional level too, right? So pre-albumin, and it is also a transport protein for thyroid hormone. Okay, yeah. So coming to the various diets here, see, in nutrition, basically, you get questions on the diet you will have to start for clients with different conditions. Okay, so now the first one is something we can call it as clear liquid diet. Clear liquid diet. What do you understand by this clear liquid diet? Clear liquid in the sense, it is clear in its form. Okay, so that is something we can call it as clear liquid, which is very clear, and its form is clear liquid diet. Okay, so what all could be clear liquid diet? See, so it should be very clear like this, and then we can call they are clear liquid diet. Okay, some of the examples are water, fat-free broth, boilon. Okay, so clear carbonated beverages, gelatin, hard candies, okay, ice candies, hard candies, lemonade, frozen fruit bars, diluted juices, regular or decaffeinated coffee or tea without milk. Yes, of course, energy drinks are something we can call it as clear liquid diet, or they come under clear liquid diet. Okay, so why these clear liquid diet has to be started? What happens after surgeries and all if you start directly with semi-solid or full liquid diet and all if you start? So what could be the problem? Yes, what could be the problem?
Vomit.
The client can vomit. Yes, exactly. Okay, so it may not be because our body was under resting state, and all of a sudden when sudden high amount of nutritious diet, if it enters inside, the body will not be able to adjust to that. Okay, so before you start introducing with any high so a fiber diet or semi-solid diet and all, so you need to trigger the body's metabolism. For triggering, so this clear liquid diet is helpful actually. Okay, so after complete bowel rest, after surgeries and all, the client will be started with clear liquid diet. Okay, yeah. So in the sense, you need to understand it is, it consists of, it doesn't consist of many nutrients, but some sort of energy it will be providing. Not very high energy, but some sort of energy. Okay, so those diets are called as clear liquid diets. Okay, yeah. And here, so these are some of the examples. You need to know these examples. Okay, so because in questions you may get some, they may include some examples, and you should be able to identify under which diet it will come. Fine. Okay, so now remember here, dairy products and fruit pulps and all, you know, they do not come under clear liquid diet. Okay, so they do not come under clear liquid diet. Moving next, full liquid diet. Now, after clear liquid diet, the client will be transitioned to full liquid diets, okay, which can include pulp forms of, so fruit pulps, okay, and juices, dairy products, pureed vegetables, okay. So these all come under full liquid diet, okay. In certain cases where only mild anesthesias were given and all, even client will be started with this, but it depends upon what kind of surgeries or what kind of anesthesia was given to the client. Okay, so these are so some examples of full liquid diet. Okay, remember, so this full liquid diet is also given for people who are having, clients who are having difficulty in swallowing and chewing as well. Okay, so for them, full liquid diet is actually started. Fine. Okay, so but these are usually high in protein. Okay, so full liquid diets, though in liquid forms, they are high in protein mostly. Right, like pureed vegetables, in the sense, fruit juices, vegetable juices, and all, you know. So they are really good. They contain really good amount of needed nutrients. Fine. So moving to the next one, mechanically altered diet. Okay, mechanically altered diet. Mechanically altered diet in the sense you bring some alteration in the texture. Okay, so for people who are having problems in chewing and all, you know, so then for them, we generally start with mechanical diet. For people who are having dysphagia, difficulty in swallowing, okay, so or for dental problems, or after the surgeries around the neck region and all, you know, so usually mechanical soft diet are added, but make sure that, so this you should not add here. So avoided aspects are nuts, dried fruits, raw fruits. Okay, so raw fruits and vegetables usually, because it can get stuck. I mean, so it becomes very hard, isn't it? So fried foods, chocolate products, smoked or salted meats, foods with coarse textures are usually avoided here. Okay, so that should not be included. But apart from that, so you can just bring some changes in the normal foods. Okay, yeah. Now there is also another kind of diet, that is soft diet. Soft diet in the sense which is very much soft in its consistency. Okay, in the sense fish, meat pieces, cheese, scrambled egg. Okay, so these all are considered as soft diet. Fine. Mechanically altered diet are the diet which we change in its texture and all, but little coarse it can be. Whereas soft diet are fish, the foods under soft diets are cheese, scrambled egg, etc. Okay, yeah. So now soft diet indications are also same, especially those who are having ulcers, difficulty in swallowing and all, you know, so they can be, and also who has difficulty in jaw, so jaw movements after jaw surgeries, and also usually they can be started with soft diet. Fine. Okay. So moving to the next diet, that is low residue and low fiber diet. Okay, so low residue and low fiber diet. Residue, low residue in the sense what? The remnants will be very less after its digestion. Okay, so that those, so those foods are called as low residue diet or low fiber, which are white bread, refined cooked cereals, potatoes without skins, white rice, pasta, and all has got very less fiber in it. Okay, but here you should avoid all the high fiber foods like fruits, vegetables, nuts, and all consist of high fiber, right? So may I know in which conditions usually low fiber foods are actually started? Low fiber. Yes? Any answer? Low fiber.
In case of duodenal ulcers or peptic ulcer?
Duodenal ulcer, yes, very good. Inflammatory bowel diseases, isn't it? Yeah, duodenal ulcer, peptic ulcer. Okay, then
In case of diarrhea.
very good. Diarrhea is one of the best options. Okay, diarrhea, because you need to understand, if I give the opposite, that is high fiber foods, now what will happen here? So there is fast movement of so the intestine, isn't it? So therefore intestinal products, so therefore low fiber diet are usually mainly given for any as you said, IBD. Okay, so then gas, diarrhea like problems, so in these conditions usually they are started. Fine. So apart from that, like mainly you need to remember the some of the foods at least that is very less in fiber content. Okay, so moving to the next one is high fiber diet. High fiber diet consists of fruits, vegetables, whole grain products. Okay, so but whenever so the client is on high fiber diet, so you should be having a very good monitoring of the bowel movements also. So too much of high fiber is also not good. Okay, so and here specifically when high fiber diets are given, so gas forming foods should be avoided. Okay, so like gas forming foods in the sense like which are those? Any examples? Do you know any examples that can? Yes.
Broccoli.
Yes,
Cabbage.
good. Broccoli, then
Caffeinated products.
cabbage, broccoli.
Potato.
Yes, beef.
Caffeinated products.
Sorry.
And caffeinated products.
Okay.
Oh,
Then oats, milk. Okay,
Sweet
onions.
potato.
Yes. Okay. So these gas forming foods should be avoided. So you need to make sure that they are not added there. So because that will cause lots of flatulence and all. Okay. Yeah. Moving to the next diet, so that is cardiac diet. So cardiac diet in the sense, the diet which is very less saturated fat, cholesterol, sodium, Okay, so these all come under the cardiac diet. Of course, you know, for cardiac diseases, we generally start with this diet. Fat restricted diet, which doesn't have much fat, like deep fried foods, okay, liver, organ meats and all consists lots of fat, and that should be avoided. May I know in which conditions mainly you provide fat restricted diet? Fat restriction.
In case of pancreatitis,
Very good. So why, tell me, why pancreatitis, liver diseases, gallbladder disease, you need to avoid or you need to restrict fat? What's the reason? Yes? What's the reason? Any answer? See, pancreas, liver are involved for what? Mainly, what do they produce?
digestion problem,
Digestion in the sense, and
absorption.
see here, bile juice, okay, bile juice, which is an essential juice that is required for digestion of fat, is released by pancreas, gallbladder. Liver actually synthesizes bile juice, okay, and it is stored in gallbladder, and some amount is released to the pancreas too. Fine. So this juice is very important for digestion or digestion of fat especially. Okay. So whatever food you take, when it reaches the intestine, so gallbladder will be stimulated to release bile. Okay. When bile releases, only this fat will get digested in the presence of bile. So if bile has to be produced and released adequately, so then there should be good functioning, or pancreas, liver, gallbladder should be healthy. If there are any conditions which are affecting these organs, so then the bile juice is affected, bile juice production is affected, in turn through which fat digestion may not occur. Okay, so therefore you should be avoiding fat rich foods in these conditions. Do you understand? So they, like in liver diseases, pancreatitis, gallbladder conditions and all, we generally provide with fat restricted diet, because so the bile juice will not be adequate to digest the fat that is present in the food due to the infection to these organs. Okay, yeah, so that's about the fat restricted diet. High calorie, high protein diet, mainly you know, like milk products, peanut butter, nuts, seeds, beef, chicken, etc., etc. Again, milkshakes, nutritional supplements, these are all high in calories and protein. Remember, high calorie, high protein is basically given for burns. Okay, so burns and respiratory conditions, COPD conditions and all. Usually for respiratory illnesses and this one, burns and all. So cancer, in these conditions, mainly high calorie, high protein diet is actually provided. Okay, so that's very important to increase the metabolism, to work on increase the healing and also, that's why. Fine. Okay, and also in respiratory conditions, mainly only if high protein and high energy is there, so the body can function to compensate the oxygen deficit and all. Okay, the client will be highly fatigued, so the demand of oxygen to decrease, and also our body should be having sufficient energy. Okay, for that purpose we require high calorie, high protein diet. Fine. Moving to the next one, carbohydrate consistent diet. It's basically present in what? Carbohydrate consistent in the sense restricted amount of carbohydrates. Okay, so wherein it's not, the client should not be given restricted completely with carbohydrates. Okay, but a little amount of carbohydrate can be added to the daily diet. So which is usually carried out in conditions like diabetes, hypoglycemia, lactose intolerance. Okay, so dumping syndrome. So what's this lactose intolerance? Any idea? Lactose intolerance?
Sugar is milk. Sugar.
Milk, yeah.
Milk.
The client having enzyme
Milk.
that is, yes, milk, exactly. To digest lactase or lactose, okay, so there should be an enzyme called as lactase. Okay, now clients who are having deficit of lactase, so then they are considered as lactose intolerant. They can't bear the moment they take any milk or dairy products, so all sort of intestinal problems, bloating and all will occur. So those candidates or those, those clients are usually called as lactose. So apart from that, what is this dumping syndrome? Any idea? Dumping syndrome you will be learning under peptic ulcer complication in detail, but still, may I know if anyone has got an idea about dumping syndrome? In peptic ulcer disease, you will be learning this. Apart from that, what's this? Any idea? Dumping syndrome.
Rapid
Gastric
emptying
emptying.
Yes, somebody is answering there. Yes.
Rapid emptying of the gastric content into the small intestine. That is called
Very
dumping
good.
syndrome.
Okay. So usually after gastric resection.
Gastric emptying, yeah.
Exactly. Okay. So after gastric resection procedures, so whatever you take, that will not stay stored in the stomach. Rather, so it will be dumped into the intestine, and then you have dumping syndrome. So further discussion of dumping syndrome will be made on Wednesday's class, wherein we will be studying about the peptic ulcer disease. Okay. So as of now, I'm holding this topic here. So what's galactosemia? Galactosemia. Galactosemia is a condition where the sugar doesn't get processed properly. Okay, so there also you will have to put on the client with carbohydrate consistent diet. Okay, next, sodium restricted diet. In hypertension, in cardiac diseases, in kidney diseases and all, sodium should be restricted, because when sodium retains, what happens there? So retention of sodium will be causing what? Retention of water. Okay, so wherever sodium goes, water will be following. So retention of sodium causes retention of water, which can increase the fluid volume in the body. Thereby, it can increase the thereby it can increase the blood pressure. Okay, so not only that, increase in sodium will create a burden to the heart also, to heart's pumping system. Okay, so therefore, mainly in cardiac diseases, so the client should be on sodium restricted diet. Okay, yeah. So moving to the next condition, protein restricted diet. So this is basically in liver conditions or kidney diseases also, renal and liver diseases. Okay, we give protein, but restricted amount of protein. Okay, so usually in liver diseases, kidney diseases and all, so this protein restricted diet is usually started. Fine. Okay, so moving to the next one, potassium modified diet. So potassium modified diet in the sense what? So depending upon the client's need, so we provide potassium. Okay, like when the client is having very high potassium level in his body, especially in what we can say in renal problems and all, so we generally provide low potassium foods. Okay, so knowing this low potassium foods are very important, I want you to know this. Foods low in potassium, please write it down. Potassium diet is very, very, very important. Okay, so these are some examples of low potassium foods, and these are some examples of high potassium foods: avocado, bananas, carrots, fish, oranges, potatoes, raisins, spinach, strawberries, tomatoes. Okay, so these are the food that are high in potassium. Fine. So remember all bananas, nuts. Okay, remember like this, all citrus fruits, dry fruits. Okay, so they are usually high in potassium. So these have to be avoided. Citrus fruits are usually high in potassium. Remember, dry fruits are usually high in potassium. Okay, so bananas are high in potassium, carrots, strawberries, and all are high in potassium. Whereas apples, green beans, cabbage, lettuce, grapes, apples, grapes, and all are very less in potassium. Okay, so you need to learn this because potassium rich diet and potassium low diet are one of the important questions. I mean, the aspect that you should know. Not only here, so under the options they will be adding, like they may, for a cardiac diet client, so they may give me in an option, they might mention like provide with apple juice. So if you know whether the apple has low potassium or high potassium, so then it is easy for you to select. Okay, so therefore it's very important to know about the dietary aspects of potassium. Okay, yeah. Moving to the next one, low purine diet. So this is given in which condition, tell me? Low purine. Purine means what?
Uric acid.
Gout.
disease.
Gout, yes, exactly. So what is purine? What is purine? Yes, what's the difference between purine and protein? Yeah, purine is basically a compound of protein. Okay, but what is the basic function? So this purine is one of the compound that generally causes uric acid. Okay, so purine is basically it is a derivative of protein. Okay, but after the protein metabolism, so this should be dissolved. Okay, so whereas here too many purines will be, and this has to be removed adequately from the kidneys. Okay, so when purines are not adequately removed, there is a background disturbance. Please mute your mic. Okay, so when you answer, please unmute and then you make sure that you mute your mic. Okay, yeah. So what I was telling was purine is a derivative of protein. So after the protein metabolism, the end product is purine. So this has to be removed adequately from kidneys. Okay, when this doesn't get removed, you know, so it will cause excess uric acid. Fine, and these uric acid will become more and more and more, and it will deposit in the I mean, so in body here and there, so especially in the joints. Fine, so that will be causing gout like conditions. Okay, so gout in the sense, what is gout? So very painful condition, it is painful condition of the joints. Okay, so mainly the large joints are basically affected here, so it's really a painful condition. Fine, so where you will be finding the deposits of purine also, or the uric acid deposits also. You will study detail about this gout in musculoskeletal disorder. Okay, yeah, so low purine, therefore the client with gout or increased uric acid level in body should be put on low purine diet. So low purine diet in the sense, the client should be avoided with these foods. Okay, so anchovies, herring, mackerel, sardine, all seafoods. Seafood should be avoided, very importantly. Seafoods are high in purine. Fine, so mainly this has to be avoided. Chicken can be given, it's not going to cause much problem. Okay, so whereas high levels of spinach also should be avoided. No spinach too. Spinach and all will consist of lots of purine. Okay, so spinach should be avoided. All pulses, cereals and all should be given in only limited form. Okay, so all protein rich diet has to be avoided. So they come under the low purine diet. Okay, so avoiding protein rich diet is low purine diet. Okay, yeah. Moving to the next one, high iron diet. You know the significance of iron. So why iron is needed for the transport of hemoglobin. Okay, so iron is very important, and egg, whole wheat, green leafy vegetables and all will generally are rich in iron. Okay, yeah. So apart from that, so have you heard about another condition called a celiac disease? C-E-L-I-C-A, celiac disease. What is this? Have you heard about this celiac disease? Yes. What's celiac disease? Yes, give your answer. Celiac. What diet?
An
GI.
immune reaction
Immune
to
reaction.
eating gluten.
Okay, so what food causes this?
Gluten.
Food rich with gluten.
Exactly. Okay, gluten, very good. Okay, so gluten rich food, allergy to gluten food is something we can call it as celiac disease. Okay, mainly the 4 food constituents you need to know. Remember, bro diet should be avoided here. Bro diet. So that should not be given. Bro in the sense, B stands for barley. Okay, R stands for rye, O for oats, and W for wheat. Fine. So barley, rye, oats, and wheat in any form should be avoided. Allergy to gluten causes celiac disease. So what happens in celiac disease? Usually when a child is in his weaning period, so this celiac disease is noted. So usually after 4 months, after 5 months, after 6 months, again depends. So when you start weaning the child, so when you start introducing barley, oats, wheat and all, so after intake of wheat and all, you notice the child to become more cranky. Okay, so you notice the child to be developing rashes and all, and that's something we can call it as celiac disease. Okay, so there will be diarrhea, and this indicates allergy to gluten diet. Fine. So for these kids, mainly bro diet should be avoided. Okay, yeah. So that is about these conditions, or the celiac disease, lactose intolerance and all. Fine. So hope you are clear with these aspects. Now, so moving to, that was all about the diet. Okay, so we don't have much to discuss apart from that. And there are certain terminologies which you already know. Vegan diet. What is vegan in the sense? Pure vegetarian. Okay, lacto-ovo diet. Lacto-ovo diet in the sense only dairy and egg products they will be consuming a lot. So that is lacto-ovo diet. Okay, yeah, so there are other terminologies that you should be aware of. Right. Okay, so moving to the next aspect of nutrition, and after this we would be doing questions on the same. I'd like to talk a few things about enteral nutrition. You know what it is. Enteral in the sense when the food is actually given through the gastrointestinal tract via tube. Okay, so the NG tube, gastrostomy tube and all. So they come under enteral nutrition. Okay, so usually the food which will be mashed or in liquefied forms. So when you give orally or through tubes, okay, so or especially through nasogastric tube, gastrostomy tube, jejunostomy tubes and all. So that is what we call enteral nutrition. Okay, yeah. But what is parenteral nutrition? This is a very important point for discussing in today's session again. Okay, so parenteral nutrition. So parenteral nutrition is nothing but, so wherein the nutrients are supplied via veins. Okay, so through veins, the nutrients are actually given. In the sense, the clients, those who are so totally those whose gastric system is not working. Okay, so colon cancer, bowel cancer, esophageal cancer. Okay, so in these conditions, so wherein the other ways are unsuccessful, so then we start parenteral nutrition. Parenteral nutrition are basically two kinds. One is peripheral parenteral nutrition. Okay, so through peripheral veins, the nutrition is transported or it is given, administered, or the other one is total parenteral nutrition. Total parenteral nutrition in the sense like wherein through a central vein. Okay, so through a central vein, the central vein is accessed in order to provide the nutrition. Okay, so these are the two ways of parenteral nutrition. Okay, so TPN and PPN we say. Partial parenteral nutrition is also there, so which is usually given through the arm or arm line and all, and apart from that, total parenteral nutrition. Okay, yeah. Now here, so mainly as I already told you, so this supplies all nutrients via veins. In cancer, in AIDS, in malnutrition, those who are receiving chemotherapy, those who are having gross limited oral intakes and all, so the parenteral nutrition is initiated for them. Okay, so you can note the difference now. So this is enteral nutrition, whatever is given through the NG tube, gastro tube, jejunostomy. So these reach the stomach, it go to the intestine, and the normal process of digestion, through the normal process of digestion, it is eliminated. Okay, so whereas in TPN, so the nutrients gets into the veins, and then the blood, and then further, so all the other actions occur, the kidney filters, and then etc, other parts and all. Okay, yeah, so that's the basic difference. Now there are certain aspects here that you need to consider. See, mainly carbohydrates, amino acids, electrolytes, insulin, heparin, lipids. So these are the added components here. Okay, so carbohydrates in the form of glucose, and electrolytes are introduced here. Apart from that, so fats are in the forms of oil, or sometimes egg products are used here. Okay, so to supply the needs of lipids and to meet the lipid levels, and heparin is added in order to reduce clot, and for diabetic client mainly insulin is also added here. Okay, yeah. Now, apart from that, no other additives should be included in the solution, right? Okay, there are other aspects that you need to remember. So before total parenteral nutrition is started, right? The first important aspect is checking for the egg allergy. Egg allergy, okay, because since the lipids are added here, the chances, if those who are already having egg allergy, the chances of developing an allergy is very high. Okay, so therefore lipids are added, but lipids mainly it is made up of egg. Fine, so oil, egg and all, and this meet up to around 25 to 30% of the energy intake. Okay, so lipids are basically formed through eggs and all, and therefore so they contain egg yolk. Since they contain egg yolk, people with egg allergies should be monitored. Okay, yeah. So then the patient's weight, nutritional status, current lab results that include everything: BT, PT, iron binding capacity, LFT, pre-albumin, albumin, creatine, everything should be assessed here. Okay, and through a special IV filter, basically this is given, administered. And apart from that, so remember not to use, see these packs, when you when it is got, if you find that there is an oily appearance or layer, so it indicates that that is not good for use. Do not use if you find any presence of oily appearance or layer of fat on top of the solution, which indicates some changes has happened and therefore it's not good to use. Fine, okay. And every 24 hours, you need to change the bag and the tube. It should not be used more than 1 day. Every new bag, every new tubing has to be taken. Okay, and all of a sudden you can't stop TPN, so it should be discontinued slowly by putting the client on dextrose in water. Okay, dextrose in water solution has to be used while tapering from this total parenteral nutrition. Okay, yeah. So now these were the aspects, important aspects under the complication, under the basics of total parenteral nutrition. Okay, so remember carbohydrates, amino acids in the form of, like they are the proteins. Okay, so lipids all are added in its equal amount. So therefore, based on the amount that is required to the body, it is added. So sometimes the complications can arise. Complications in the sense, let us see, so which are all the different, or what are the different types of complications, so that generally arises. Okay, first one is air embolism. You know that through the tubes, so since we are inserting it to the veins, so sometimes while changing and all, air entry can happen, isn't it? So that will cause air embolism. So if there is air embolism, so then what you will be finding in the client, what all could be the complications? Any idea? So if there is air embolism, how you will identify or how you will determine that there has been a complication? What would be the
patients suffer from chest pain, shortness of breath.
Pain. Very good. The client complains chest pain. Yeah. Then apart from that,
hypotension.
Yes?
Hypotension.
The pressure will go down. Okay, very good. So then what? Then what?
Respiratory distress.
Distress will be there. Okay, so then what are you going to do here? How about the pulse and all? Pulse, whether it is going to be bounding or weak?
Big pulse.
Weak.
Weak pulse. Okay, so weak pulse. Hypotension, because the client's blood pressure will go down here, so due to air embolism, so dyspnea, breathing difficulties. Okay, the client will be extremely, you find him to be worried, okay, having a weak pulse, and these are the signs and symptoms. Usually, as I told you, air entry, mainly the main reason for air entry is during the catheter change. Okay, so that is the main reason for air entry. So now what are you going to do here? You need to clamp all the ports of the IV catheter, okay, and place the client in a left side lying position with head lower than the feet. Okay, so this is head lower than the feet position. So so why is this position given? Any idea? So why is this position given?
To trap air in the
Wow.
right side of heart.
So to
Air
trap
goes to the
air outside, yes, air
From the
doesn't
heart.
enter into the heart. Very good. Okay, so that's why we give the client with head lower than feet. We don't want the so air to enter into the circulation, the systemic circulation. Okay, so therefore we are giving this position, head lower than feet position has to be given. Okay, so then the physician can be notified, and if required, if the saturation is going or down, or if the client is extremely distressed, then you can also start with oxygen. Okay, so these are the ways how you will be managing the air embolism. So that is one important and major complication because of this TPN. Fine. The second one is pneumothorax. So you have learned about pneumothorax in the respiratory system. So what's happening here? So air has entered into the chest and the lungs, and it is accumulated in the pleural space. Pleura is the covering of the lung, and inside the pleura, the air has accumulated. Okay, what could be the reason? Why can this happen? Tell me. So when do this happen? Yes, when the catheter placement is wrong. Okay, so we have to insert the catheter, so in the subclavian vein. Okay, sometimes when the catheter placement go wrong, so this pneumothorax, it can cause this pneumothorax, which is evidenced by the client will be having too much of shortness of breath. Okay, so sometimes bluish discoloration, cyanosis, breath sounds will be absent. Okay, so we have learned about the pneumothorax signs and symptoms under the respiratory system. Okay, so what are all? Do you remember? So do you remember all those aspects? So here when you auscultate, what is the problem? You will not hear breath sounds. Breath sounds will be very weak. Okay, so then cyanosis, tachycardia. So these are the symptoms. So this will indicate that the client could be having pneumothorax, and he should be, what he has to be done, he has to be, if pneumothorax is noted, then through chest tube drainage system, he has to be attached to the chest tube drainage system. So that will aid in the drainage of the air, fluids and all. Okay, so assessment of pneumothorax is very important, and after checking you need to confirm in an x-ray, so whether there was catheter misplacement. Okay, and then you will have to start correcting the condition. Okay, so that is, you need to make sure, see, immediately after notifying the HCP, you can expect that the client will have to go in for an x-ray to determine the exact problem the client is actually having. Okay, yeah, so these are the two major complications of this total parenteral nutrition. Apart from that, hypervolemia in the sense the fluid level can become more fluids in the body. Okay, so what are the manifestations of excess fluid in the body? Please answer. Those have finished with the previous classes can answer.
Swelling, edema.
Exactly.
And
Edema.
Then
crackles.
Crackles, the sound, the wet bubbling sound that you hear on auscultation. Okay, so that is crackles. Apart from that, how is the pulse? JVD.
Bounding pulse, ma'am.
Bounding pulse. Very good. Apart from that,
Weight gain.
Weight gain, yes. Okay,
Hypertension.
hypertension, very good. So what can we do here now in these conditions? Can you continue with the fluids?
No, we need
Slow
to slow or
down.
stop.
You need to stop. Okay, so then what can be done here to remove the fluids from the body? What is done? What's that?
Give diuretics.
Diuretics are,
Diuretics.
okay, so diuretics are basically used under the management for hypervolemia. You should learn the signs and symptoms of fluid volume deficit and fluid volume increase. Okay, so please don't. Yeah. Moving to the next one, hyperglycemia. What could be the reason for hyperglycemia? Any idea?
Ma'am, due to continued TPN or PPN, hyperglycemia can cause.
Yes, in the sense hyperglycemia occurs for people in whom insulin is not given. Okay, so when insulin is not given, hyperglycemia can happen, and also when there is too much of glucose in the solution, hyperglycemia happens. All sorts of signs of increased blood pressure you can see here. The client will be having too much of thirst, fatigue, okay, so and weakness, and all these are the manifestations. Now what we can do here, tell me? We can give insulin here. Okay?
Insulin.
Yes, exactly. So that's what I was saying. Insulin can be given, okay, and based on the condition, the further treatments are usually provided. Fine. Okay. So the next important condition is infection. Infection. Since we are inserting to the central line, peripheral line, and all, so high asepsis has to be followed. Okay, when proper aseptic methods are not used, the client, it can cause infection. Okay, so when there is infection, what are the signs and symptoms? What are the signs and symptoms?
Fever.
Fever.
Good. Fever,
Increased
Increase
WBC.
WBC.
yes,
Redness.
increased WBC. Okay, so these are the signs and symptoms. So what will you be doing there? So when there is fever,
Antibiotic.
Administering antibiotics.
antibiotics.
Use
Okay,
aseptic techniques.
Remove the catheter.
Maintaining septic technique.
okay, catheter it has to be removed. Very good. Catheter has to be removed. That should be the initial step. Good point that you have added. So after notifying the doctor, you will have to remove the catheter. Okay, so then you can even send the catheter and also the client's blood for obtaining the culture. Okay, so then after getting the culture itself, always if you are having two options where there is obtain culture and start with antibiotics are there, so make sure that you select obtain culture as the first, the basic assessment that should be carried out, or the basic action that should be carried out. After that only, after getting the culture report only, we can start with the antibiotics. Okay, so you need to know that. Fine. So these are the aspects that should be carried out. So when there is infection. Okay. Yeah. So these are the main complications associated with this parenteral nutrition. See, this parenteral nutrition, depending upon the clients, we can administer. It can be given continuously also for 24 hours. Sometimes for some people, they will be giving it intermittently, in the sense for 8 hours in a day. Likewise. Okay, so always remember, so before discontinuing this parenteral nutrition, so first you have to, all of a sudden you should not stop. Rather, you should first slow the rate of this one administration. Okay, so the rate should be slowed. Fine, and after that, the only you can actually stop this. But before stopping, the client will be given with dextrose in water. That is another thing. Okay, and soon after you should be removing the catheter and seal properly without infection. Okay, so these are the basic aspects that should be followed. And suppose if you note the client to be having infections, immediately inform the doctor. And but suppose you can also, if the doctor says, so the catheter can be restarted at different sites also, but the client will have to be, you need to send the catheter tubing, and the blood should be sent to the lab for checking the, or for knowing the, for culture, and after that only the antibiotic can be administered. Okay, yeah. So these are some of the complications, the nursing actions and all, as well as some points under the total parenteral nutrition. Is that clear? Okay, so any doubts you are having here? Any doubts for clarification? Okay, so we'll move to the questions then. Okay, so here is the first question. The nurse is reviewing laboratory results and notes that a client serum sodium level is 150 MEq per liter. Okay, the nurse reports the serum sodium level to the primary healthcare provider and he prescribes dietary instructions based on the sodium level. So which acceptable food items does the nurse instruct the client to consume? Give the answer. You can give your answers in the chat box. Just a minute, give your answers. Yeah. Yes. See, others, please give your answer in the chat. Put your answer in the chat box. There are 46 and I'm not getting many answers. Yes, it's very easy, isn't it? So, right, 1, 2, and 4 are the options. Okay, so that can be selected. They do not consist of sodium much. Whereas cheese and any processed food, remember, any processed food, so usually consist of sodium. Okay, so therefore, so 1, 2, and 4 are the right answers. Yes. Moving to the next one. The nurse provides instructions to a client with low potassium level, low potassium, about the foods that are high in potassium. Okay, low potassium level about the foods that are high in potassium, and tells the client to consume which foods. Can you give me the high potassium foods list here? Can you select? Waiting for your answer. I want all of you to try. Okay, so please try. High in potassium. 1, no, peas do not contain potassium. It's low in potassium. Raisins, potatoes, do they consist?
Yes, ma'am.
Yes. 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 Potatoes, fine. Okay,
Yes.
potatoes consist of high potassium. Cantaloupes?
Yes, ma'am.
Yes.
Yes. Cauliflower?
No.
No.
No, ma'am.
Strawberries?
Strawberries. Yes.
Yes, ma'am.
2, 3, 4, 6 are the right. Okay. The nurse is caring for a client with cirrhosis of liver. To minimize the effects of disorder, the nurse teaches the clients that are high in thiamine. Okay, so the nurse determines that the client has the best understanding of the dietary measures if the client states an intention to increase the intake of which food. So that is needed.
Second.
Okay.
Fourth one.
Liver when it's affected, you know, so I mean, so you will have to focus on thiamine foods. Okay, so thiamine is basically under which vitamin does it come? Any idea?
Vitamin B2.
Vitamin.
B vitamins, B1.
B1.
Okay, yeah, so this is needed for the See, vitamin B generally is needed for all the nerve diseases and all. Okay, so now thiamine is very essential. Now the question is, like, I mean, which is the right option for the client? Okay, so the nurse determines that the client has best understanding of the dietary measures to follow if the client has an intention to increase the intake of which food.
Legumes.
Thiamine is mainly present in what? In plant products. Okay, so legumes are the right answer. Very good. Okay, thiamine is the component that is very, I mean, so it's really found plenty in plants, mainly in plants, and of course, animal also it's there. So animal origin in the sense, pork and all consist of thiamine. Otherwise, nuts, cereals, basically consist of thiamine. Poultry generally don't consist of thiamine, so rather it's said that the poultry consists of niacin. Okay, so therefore that cannot be selected. Broccoli consists of other essential elements like C, vitamin E and all. Okay, so legumes is the right answer for this. Yeah, moving to the next question. A client who is recovering from surgery has been advanced from a clear liquid to full liquid, from clear to full. The client is looking forward to the diet change because he has been bored with the clear liquid diet. The nurse should offer which full liquid item to the client? Very easy question, isn't it? What's that? Yes, custard. Okay, so option 3,
Custard.
custard. Very good. So that was very easy. Okay. Fine. So next one. A postoperative client has been placed on a clear liquid diet. The nurse should provide the client with which items that are allowed to be consumed on this diet? SATA.
1, 2, 3.
Yes, that's right. Okay, so very easy. 1, 2, 3. This vegetable juice, pureed vegetables, pudding and all, they come under full liquid. So clear liquid, broth, coffee, gelatin. Okay, so coffee, no milk, decaffeinated coffees. Okay, so they have to be given. Fine. Okay, moving to the next one. The nurse is preparing to change the parenteral nutrition solution bag and tubing. The client's central venous line is located in the right subclavian vein. The nurse asks the client to take which essential action during the tubing change? Okay, so now you want to change the tubing. So what should be done during tubing change? Think. What should be, see, you learned, what did you learn? So this is how NCLEX focuses. Okay, you have learned that during tube change, air entry can occur, so that can cause air embolism. So you need to think, what if I advise the client, can this air entry be stopped? Okay, or air
Fourth,
will be avoided.
fourth
Yeah.
one, ma'am.
Okay, so fourth one, very good.
Valsalva maneuver.
Valsalva maneuver. Okay, take a deep breath, hold it. When the client doesn't breathe normal, I mean, so if he doesn't breathe this, you know, the chances of air entry is highly reduced. It's highly reduced. Okay, so this helps in avoiding the air embolism. If he is normally breathing, so what will happen? So it will create a way for entry of air during the tube change. Okay, so you have to focus here. See, what is the most essential in the sense that is required in this situation. Always focus on the terminology, these strategic terms in NCLEX questions. Okay, so that will help you to give the right answer. Essential in the sense which has to be done, you cannot avoid it. Okay, so take a deep breath, hold it and bear down is the most essential step. Moving to the next one. A client with PN infusion has disconnected the tubing from the central line catheter. The nurse assesses the client and suspects an air embolism. The nurse should immediately place the client in which position? Immediately place the client in which position?
Number 1.
First one, ma'am.
First one,
Left side with the lead.
yes, with head lower than feet, isn't it? So that is what we had discussed. Yeah, so head lower than feet. So what will happen? So when head is lower than feet, you know, the air that travels to the lungs, okay, is actually blocked here. Okay, so when the client is basically turned to the a left-sided position, see, I mean, so you need to understand the concept here. So to be more clear, so let me see, suppose if this is the, you know, like the anatomy and functioning of the heart and all, isn't it? So the right side, the left side is more involved towards, see, in the left side, the pulmonary, the right side, the pulmonary artery emerges and it goes to the lungs. In the left side, aorta, isn't it? It goes to the body parts. Now, the air that is coming from the vein, okay, so it's coming from here, it's traveling here. Now, anytime it can enter into the heart, and if it goes down, it will go into the pulmonary artery, and this through this pulmonary artery, it will go to the lungs, the air emboli. Okay, so then that will be of greater distress. Fine. So now, in order to stop this, you will turn the client to the left side. So when the client is turned towards the left side, what will happen? The pressure that will build up here will make the air emboli trap here itself, okay, in the right side itself. So it will be trapping there, here. It will not enter into the this one, the pulmonary artery. Okay, so thereby the problems can be minimized. And that is the reason, so this position is usually given, left side turning and head down position, so that we can prevent the air emboli by trapping it in the right side itself. So the here itself, it will be trapped. Okay, so it will not enter into the pulmonary artery. And that is the reason, so why this is given. Okay, yeah. So therefore, so this option 1 is the right answer. Fine. So moving to the next one. Which nursing action is essential? Again, it is essential in the sense you need to do it. Okay, so essential prior to initiating a new prescription for 500 ml of fat emulsion to infuse at 50 ml per hour. Essential, which is needed. Yes.
Second one, ma'am.
Allergy to eggs?
Yes, ma'am.
Yes.
Second one.
Yes. Very good. Okay. So this also, you know, all are easy questions under nutrition. So allergy to eggs. Fine. Okay. Moving to the next one. The client receiving parenteral nutrition complains of headache. The nurse notes that the client has an increased blood pressure. Bounding pulse. We should understand bounding pulse means what? What could be the problems here? Jugular vein distension. These are the indications of what? Crackles. What do these signs? Hypervolemia.
Hypervolemia.
They are the indications of hypervolemia. Okay, so the answer is hypervolemia. Very good. Yeah. So that's all. Okay, so we had only so many questions under nutrition. Okay, so I believe you have understood the main concepts of nutrition. Please understand the different types of diets that are given to the client. Okay, transition diet after surgery, all those transition diets you should know. Okay, something about celiac diet, lactose intolerance. Okay, so something about parenteral nutrition and its complications are very important. What to do, or what are the signs and symptoms that can indicate complication. Okay, so all these aspects are very important under nutrition, right? Okay, so that's all about nutrition. So now I would be giving you a short break of 10 minutes. So after 10 minutes, we can get back once again for discussion on the next topic, that is gastrointestinal system, okay, and its disorders. Fine. Okay, you can take a short break now. Hi all. So welcome back. Okay, some of you have questions on previous recorded classes. See, if you are new, in the sense like you need to be added to the Teams group. If you have already been added to the Teams group, I think so. Like I mean, so you would have noted a tab called as Zoom recordings. Okay, so in your Teams group itself, so left side, right side, yeah, there is a tab. Like, can you say which side it is actually? It's towards the right side, right? So there's a tab on Zoom recordings. Yeah. So those who are already listening to the recordings. So please note that there is a tab called as Zoom recordings. Okay. So in that tab, under that, all the recordings would be uploaded. Okay. Yeah. So there you will be getting the recordings. Okay. Any other doubts? And for any other technical related queries and all, you can contact Nimi as well as Praveena. Okay, so they will be sorting out your queries. So all technical related, any joining errors or any quiz. I mean, so if you are finding any difficulties in accessing the questions, resources, anything, so please contact Nimi and Praveena. So they will be sorting out your queries. And for all I mean, so theory related, academic related matters, you can contact me. So via Teams. So you can just type in my name and you can put in your concerns, like any doubts, or while doing questions, you will come across many aspects where you will be really confused. Why this answer? Why not that answer? Or is this right answer? Or how can this answer be related? Like that, many. Okay, so you can just take a screenshot of all the concerns that you are having, and you can just put into my I mean, so in my name, like either you can email or also you can just drop in your screenshot in the chat box. Okay, so I will be assessing you. Okay. see, SATA questions and all, I will be explaining on that. So in a week or two, we are having a session on NCLEX tips. So there I will be detailedly explaining about how to answer the SATA questions. Okay. And mainly while answering SATA questions, you need to understand what the question is asking for. Okay. So then for that particular question, what answers could be right? You need to consider all options. You need to consider it as true or false, whether this answer is true for this question or whether it is false. Okay, you need to go in that way. And always while attending SATA, you will be coming across many aspects like frequencies or the signs and symptoms and all. So whenever you are confused, just read those options again, check whether the answer is right to your particular question that they have asked. Okay, or whether your whether the frequency that they have mentioned, for example, neurological checkup perform every 3 hours, so that is actually wrong. In emergency situations, when a client is admitted under observation, we do neurological assessment hourly, isn't it? So hourly assessment, so you need to check for frequencies also. So there also you may go wrong. Okay, so for clients who are having so fluid volume excess, they would have given restrict fluid to 4 liters per day. That's wrong. Okay, 4 liters in the sense that's plenty, isn't it? So they should be either be restricted to 1 liter or less than that. So in those ways you can go wrong. Identify where you're actually going wrong. Okay, so while doing SATA questions. But okay, so you will be as you practice every day, so you will improve. You can just see that. And there is separate SATA questions assignment under the quizzes. Okay, so under the NCLEX assessments, you can even access that and you can practice all those SATA questions. Okay, I don't remember the exact number. So there are plenty of SATA, I think around 100, if I'm not wrong. I don't know. Yeah, so need to check that. Right? So, okay. Any doubts, make sure to put in your concerns into my chat box and I will be answering you via Teams. Okay. Okay. So let me continue with the next aspects. Okay, so we have finished with nutrition and now I'm going to start with gastrointestinal system. Very interesting system and also easy system, gastrointestinal system. So not like last week's topic, neurological. This week's topic is really, really easy, gastro. And like in gastro system, mainly the questions come from cirrhosis of liver, peptic ulcer disease, and some of the aspects under the abdominal assessment and diagnostic tests. Okay, colostomy, ulcerative colitis, and of course medications are important here. Antacids, H2 receptor antagonist. Okay, so those aspects you have to focus. So I'd like to share my screen here. So these I'm going to talk about the very, very, very basic aspects. So now, so coming to the mouth is involved in breaking the major food stuff into minor particles, isn't it? So after that you swallow and it passes through the esophagus. Now in esophagus, what are the essential parts? There are basically structure that you need to consider under esophagus. Which is that structure that is present here at the entrance of stomach? Any idea? What's that called as? There's an opening.
Cardiac sphincter, the sphincter, cardiac
sphincter. Very good. Okay, cardiac sphincter or esophageal sphincter. Cardiac or esophageal sphincter. Okay, see, this structure opens up and it will allow the food that you have taken, or it will help in moving into the stomach. Okay, so the structure that is present here at the entrance of the stomach. And once the food enters here, so this will close. Okay, close in the sense it will become totally, so it will make sure that the food is not regurgitated back once it enters the stomach. Okay, so now in some cases, or especially in pediatrics and all, so before attaining age 1, you would have seen them vomiting all the time, isn't it? So what is that? Why do they vomit so much?
GRT.
Yes, that is a reflex that they are having, and that is because their sphincter is not well developed. Okay, so that is because their sphincter, the esophageal sphincter, is not matured in babies, in newborns, and that is why when the stomach is around 3/4 full, easily it will come out through the esophagus. Okay, this is very much normal in the case of infants. As they grow, it will mature, and in adults, if the same condition is happening, so when it, whatever you, after eating and all, if you are having excess of regurgitation, heartburn, vomiting and all, what is that condition called as? GERD. Okay, gastroesophageal reflux disorder, or we can also call it as GORD, GORD, depending on how people pronounce it, you know, how they write esophagus, it will differ. GORD or GERD we call it as. Okay, so which is nothing but a reflux disorder. I will be talking about this later, but as of now, you just remember these aspects. Okay, cardiac sphincter will make sure that the food contents doesn't come out. Okay, but there are many reasons when cardiac sphincter can lose its elasticity, when client are on certain medications, when a client is obese, okay, when the client is exposed to too much of stimulants and all, you know, so this cardiac sphincter can become relaxed, and this will let out everything that has been taken, leading to a condition called as GERD. Okay, the GERD management and all we'll learn later. Coming next to the stomach, now you have eaten and the food entered into the stomach, and here the knowing the retention time of food inside the stomach is very important. Why? Because like when it moves out of the stomach, so what will happen? Like, I mean, so any idea about the retention time? How much time does the food retain inside the stomach? Yes? Any answer? Depending upon the type of food you take, it will differ slightly, but however, around 45 minutes to 60 and to 90 minutes, it will differ. Okay, maximum 1.5 hours, food will be retaining inside the stomach, where mixing with HCl occurs. Okay, hydrochloric acid and other juices, it occurs. Okay, and after that, after 1.5 hours, so it will move into the small intestine. Now, why this is important, I said, is because see, when the food is there, so soon after eating food in half an hour, if you are having too much of stomach ache and all, that indicates gastritis, which could be a peptic ulcer disease also. Okay, related to gastric ulcer. If after 2 hours after you are sleeping in middle of the night and if you wake up with stomach ache, so that can indicate that you are having duodenal problem. Okay, so that is why I said, so knowing the time is important here. So how long does the food retains inside the stomach? Okay, yeah. So now here also, before it enters into the small intestine, there is another sphincter present at the entrance of the small intestine, and we call it as pyloric sphincter. Okay, pyloric sphincter. This will allow the food contents from the stomach to move into the intestine, pylorus or pyloric sphincter. Okay, yeah. So moving next, then the food enters the small intestine, from there large intestine. Okay, and after that all the absorption, water reabsorption occurs and it is eliminated. So this is one way or one form of digestion, but this is the direct path of digestion, but there are added parts which without which the digestion will not be complete. They are nothing but liver, gallbladder and pancreas. Very important structures. Okay, so liver, gallbladder and pancreas. In that, liver is the major structure, or which is the major gland we can say, or largest gland we can say, liver. Okay, now here, so these liver itself consists of separate circulation, and that circulation is called as, these are all just basics, I'm just reviewing your basics. Okay, so because if you know the basics, you will, it will be easy for you when we discuss the conditions. So that's why I'm just reviewing the basics. So what's the separate circulation that runs inside the liver?
Hepatic.
Water circulation.
Portal circulation. Very good. Okay, portal veins. Okay, so they are present in liver. Portal circulation. Hepatic circulation also we say. Okay, the cells of the liver are called as hepatocytes. Fine. So liver carries out, or liver synthesizes all the fat, glucose, amino acids, protein. Okay, so it will help in digestion of carbohydrates, proteins. It will store blood, it will store vitamins. Okay, so it will synthesize bile. So bile is nothing but, so the bilirubin, the end product of RBC is bilirubin, and this bilirubin is converted to bile through the liver. Okay, liver secretes bile. Without bile, fat digestion will not occur. Okay, for fat digestion, liver secretes bile. So you need to understand, if liver is under trouble, bile secretion will be affected. If bile secretion gets affected, so there is no digestion of fat. Okay, so that's very important. See, RBCs has got a lifespan of 120 days, isn't it? So after this lifespan, it will break. And once it lyses or once it breaks, the products are bilirubin. Okay, so this bilirubin has to be synthesized as bile by liver, and then the bile juice will be stored in gallbladder. So pancreas also release some bile. Okay, and then this bile juice will mix with the food that is present in the small intestine, especially with the fat and all. It will help in fat digestion. Okay, and after that, the bile juice is eliminated out through the large intestine. Okay, so it is eliminated out through in the form of feces. Okay, that is why, because the bile, or because the stool has the presence of bile in it, the stool color is brown. Okay, so if the stool is absent of bile, like for example in jaundice, in conditions and all, what is happening there in jaundice? So in jaundice, in the sense the liver is affected, isn't it? So the liver is under inflammation, or it is inflamed. So the liver doesn't perform normally. It is not involved in secreting, in synthesizing bile and all. So if you have fat rich diet in jaundice, so you usually vomit. Okay, or else the fat will not get digested. So because there is no bile to digest the fat in the food. Okay, and if fat is not digested, the fat will be let out in the same way without mixing with the bile juice, and then that stool is called as steatorrhea. Okay, STEATORRHOEA. Steatorrhea means presence of fat in the stool is called as steatorrhea. And in that case, the stool color will be clay colored. Okay, if there is no bile in the stool color will be clay color. So this kind of stool you will be finding in jaundice conditions, okay, or in liver conditions. Fine. So do you understand? So these all are related in one or the other way under the NCLEX questions. So you need to learn the significant functions of liver and how it is involved in processing of the bile, synthesizing bile, and how the other processes occurs. Okay, yeah. So gallbladder is the structure that is basically responsible for storing the bile. Okay, so and when the food reaches the duodenum, so the a signal is sent to the gallbladder. Okay, so and this because of this signal, the gallbladder opens up and it will release the bile. Okay, gallbladder is basically responsible for storing the bile. Okay, yeah. So then what about the pancreas? See, pancreas is another important structure which has got mainly two important functions. One is exocrine function and another one is endocrine function. Okay, endocrine function you will be learning under endocrine disorders. That is insulin formation, production, all those aspects, diabetes and all you will be learning under the endocrine disorders. So what is this exocrine function? Exocrine function is nothing but, so through the ducts, it also has got ducts. Through the ducts, when food reaches the intestine, it will be releasing enzymes like tryptase, amylase and all. So in order to digest the food. Okay, so that is the exocrine function. Exocrine gland also secretes sodium bicarbonate to neutralize the acidity and all. Okay, and enzymes also it will release, so that will help in the digestion. You understand? Okay. So these are the main functions or the main parts of the GI system and how it actually functions. Okay. Now there is also one more structure called as peritoneum. So what is this peritoneum? Peritoneum is nothing but a membrane. So that is present in the abdomen. Okay. So this peritoneum, so that is this membrane. So it will make sure that all the organs are actually protected. Peritoneum. Okay. So it is only a membrane. So that is there in the abdomen. Fine. So in other way, you can say that the membrane of the or the liner of the abdomen, we can say. Okay. So it is actually a little thick. And it is vascular also. It consists of numerous blood vessels and all. Okay. So that is and it also secretes some dilute fluid called as peritoneal fluid. Fine. So the membrane that lines the abdominal cavity is something we can call it as peritoneum. Fine. Or we also call it as tissue, peritoneal tissue. Fine. Okay. So these are the main structures of the gastrointestinal system. Fine. Okay. Now, let us move to the different diagnostic tests that are carried out here. So in these conditions, the first test is upper gastrointestinal study or barium swallow. Barium swallow. Okay. So this barium sulfate is made to swallow. So it is mixed in the water and the client is asked to drink the barium sulfate. And after the client drinks, so through the cameras, the images are captured. And if there is any problem in the upper digestive system or in the upper tract, so this barium gets, so wherever, suppose just imagine the esophagus has a tumor. Okay, so then the barium capture, so the X-ray, the image captures where in the esophagus region and all, where the tumors are there, it will be highlighted. So thereby we understand that there is a problem. Okay. But after this barium, so this is a very sticky component and you need to provide a client with lots of fluid. So this is very important. Okay. And also inform them that the stool will be white in color for next 2 days. Okay. So white colored stools will be, so defecated. Okay. So that is these are the two main points that you will have to educate the client. Okay. Yeah. That is something about the barium swallow. Is that clear? Fine. Moving to the next one, endoscopic procedures. Okay, there are many endoscopy, upper endoscopies, there bronchoscopies there, which is done to visualize the bronchi. Endo in the sense, so it is basically inserted and it will move down so that all the abdominal wall, the abdominal surfaces and all are actually visualized properly, in the sense abdominal wall, in the sense the duodenum, the stomach and all are actually visualized properly, and if any problems are there, so that is identified. At the tip there is a camera, so which will be capturing everything. Okay. Now here, so there are some important nursing aspects after this, that is after endoscopy. Okay, so since see, the client will remain on NPU for 2 hours, not more than that. Okay, and this should be carried out till the gag reflex returns. After the gag reflex returns only, you are supposed to give some fluids. And how do you assess for gag reflex whether it has come or not? Any idea? How do you assess for gag reflex?
Vowel sounds.
Vowel sounds. Apart from that, vowel sounds. Vowel sounds are assessed. Specifically for gag reflex, what do you do?
Stimulate the posterior part of tongue or pharynx.
How do you do that? How do you do that? How the stimulation is carried out?
Tongue depressor. Giving water.
Using a tongue depressor. Okay. Yeah. Sometimes even a sip of water is given and we check whether the client is swallowing or not. If swallowing is attained, so then that indicates the client is, so he can be started with some clear fluids and all. Okay. So, and only after this, you can allow the client to have something. Okay. You need to make sure that the gag reflex is present. And the next important point is monitor for perforation. Because of this procedure, sometimes the bowel can get perforated. Okay, you need to monitor for that. Okay, so in the sense, if the client has any high temperature, that indicates some infection. Okay, so or a bleeding or unusual difficulty in swallowing. So these symptoms should be immediately notified. Pain, immediately notified, because they are the signs of perforation. Very important point. Okay, so please note this. So moving to the next one. See here, there is another endoscopic procedure which we call it as capsule endoscopy. Here, it's not, it's a very easy one, because the camera is in the form, so the images are taken in the through the camera, which is only a size of a capsule, and the client will be made to swallow it. Okay, so this will, and meanwhile, she will also be attached with a transducer. You can see here a transducer, a belt is there, and after the camera is swallowed, the camera captures all the images and it is transferred to this receptor here. Okay, so then, so the camera, so this capsule is eliminated out through the fetus in 2 days, whereas these images you can take at that time itself and you can attach to the system and visualize. So you will come to know whatever problems exist. Okay, so this is capsule endoscopy. Do you understand? Capsule endoscopy. But here, before this, any gastric procedure, make sure that your client is on NPO. That's very important. Okay, yeah. So coming to the next one, gastric analysis. Note the pH of gastric. So under NG tube insertion, you would have learned about all those the gastric important concepts related to NG tube insertion, aspiration, the gastric fluid and all. Okay, so and I'm not going to discuss that again. Just remember, in gastric analysis, through NG tube, you will be aspirating the contents and you will be checking for its appearance. So how much it is, above how much volume when you aspirate, you need to consider that something is wrong or it should be notified. Tell me. Before last week, there was a class on care of tubes, right? Above how much ml is considered to be notified when you aspirate?
More than 100 ml.
30, 100, more than 100.
More than
50
300.
ml.
More than
300.
300?
100. More than 100.
100, ma'am.
Not 300. Okay, yeah. So note the gastric pH 1.5 to 3.5. Okay, yeah. So moving to the next one, colonoscopy. So colonoscopy, similar to endoscopy, here also a flexible tube is introduced, whereas through the colon it is. Okay, so in endoscope it was orally, here through inside the colon it is inserted, and then so you will be so the similar, the procedure, the other aspects and all are same. So wherein the images are sent or they are captured. Okay, so in this tube, and that is what we do here. And whereas here also you need to check for the signs of bowel perforation. This is very important. Okay, so if the client, please note these signs of bowel perforation, they are very important for NCLEX. If the client, if there is any increased temperature, chills, pallor, abdominal distension, restlessness, tachycardia. Okay, so they are considered as the important signs of bowel perforation. Again, they are very, very, very important. Right? Okay. So, and also after the enema procedure, so the client should be assessed for any fluid and electrolyte imbalance. Okay. So remember here, if the abdomen is very rigid, okay, board-like abdomen, so then that sometimes in the question, in the options, they give it as a rigid abdomen. Note this point, okay? So these all indicate that they are the signs of bowel perforation, board-like, rigid. Okay, so remember this, fine. So moving to the next endoscopic procedure, that is ERCP, endoscopic retrograde cholangiopancreatography. This is a procedure where an endoscopic procedure itself, whereas even the retrograde cholangio, in the sense gallbladder, cholangio is gallbladder Pancreas and all are actually visualized here. Okay, so that is the only difference, and other aspects, the care and all are similar that you will be following in the other condition, whatever was there, you know, the same thing. Okay, yeah. The next one is paracentesis. The procedure, the position of paracentesis is very, very, very important. Okay, position the client in upright position. Whenever, in which conditions paracentesis is done, tell me. In which problems?
Ascites.
Ascites. Okay. Ascites occurs mainly in which condition?
In hepatic cirrhosis of liver.
Here, in cirrhosis of,
Cirrhosis of liver.
yes, very good. Okay, so whereas after this paracentesis, you know, so that could be a complication and you need to monitor further, because suddenly the pressure is getting down and therefore the client can be hypotensive. So as everything is pulled down, you know, so there is the pressure goes down. Okay, and there is a dilation of the cells, vessels, and this will cause hypotension. So you need to monitor for the blood pressure very importantly after the procedure. Note down this point, monitoring for blood pressure. And apart from that, so you should also check the abdominal girth before and after procedure. Before how much it was, after removal of the fluid how much it is, so that when the next day when you assess, your next day again you have to assess for the abdominal girth, you will understand how much it is getting accumulated. And also you need to check the weight, whether how the weight differs every day. Okay, so that's also very important. So these are the aspects under the paracentesis. Liver biopsy, another procedure wherein any abnormalities in liver are identified. Liver biopsy, before doing this, see, liver is basically responsible for producing the clotting factors, isn't it? So therefore, so liver, before liver biopsy, you have to carry out coagulation test. Okay, because if, see, liver biopsy, when do you do? So when you are doubtful that liver has a problem, so then we go for liver biopsy. If liver has a problem, obviously, usually the clotting factors also would be affected, isn't it? Okay, so therefore, if a client is scheduled for liver biopsy, you need to carry out the coagulation test. You need to be knowing the prothrombin time and all to check the, because after biopsy, you know, the client should not be bleeding a lot. In order to know the bleeding time, the prothrombin time and all, you need to carry out the coagulation test before liver biopsy. So that's very important. Okay, and the client can be given supine or left lateral position because the liver is present in the right hypochondriac region. The client can be given with left position, but after the procedure, the client is made to lie on the right side. Okay, after the procedure, the client, so that with the pressure, the bleeding and all can generally be reduced. Okay, yeah, so that is something about liver biopsy. So these are some of the laboratory studies, mainly liver enzyme levels. No need to learn so much, but still just remember the basic of these levels. ALP2, okay? So all are enzymes, all are the liver enzymes. Prothrombin time, if it is increased, then that indicates liver damage. So whenever there is prothrombin time, I want you to focus on the therapeutic range also. Please note this, okay? So therapeutic range is very, very important. Not only for this, for any other drugs also, therapeutic ranges you need to focus here. So in exam, this will be confusing. Okay, so the levels, so this is the normal level up to 12.5. When the client is on therapeutic, okay, the therapeutic range will be 1.5 or 2 times greater than the normal level. Okay, so the client chart and exhibit kind of questions, client charts will be given, and there they would have mentioned that under the list of medication the client is on heparin or warfarin. Okay, and under the options they will give the value as 35 or 45 and all. Okay, so in that case you should not think 35, 45 and all is high, which means that the client is at of risk of bleeding disorder. No, wrong. Okay, because if you had focused the medication chart, so there is heparin. Okay, so in that case, so this range is therapeutic. You need to consider in that way. Okay, so that kind of thinking should be developed while you do questions. So please understand. Okay, so normal ranges and its therapeutic range also you need to learn. The therapeutic range is also given to you. It's there in your resources, isn't it? So therapeutic range and normal ranges. So please learn that, especially therapeutic range of heparin, warfarin. Okay, so then digoxin, theophylline. Okay, all these therapeutic ranges you need to learn, right? Okay, moving to the next one. So that was about the laboratory studies. Yeah. Yeah, and yeah, there's one more bilirubin levels also. So bilirubin, the total is one up to 1. Indirect goes to 8. Okay, direct goes to 0.3. Should be lesser than 0.3. But together, remember, the total bilirubin level should be lesser than 1. Okay, in the case of adults. In children, it can go up to 5. So whereas in normal, in adults, in newborn, it is up to 5. Whereas in adults, it's up to 1. Okay, 1 is above 1. If it goes bilirubin, then the client can be considered as having jaundice. Okay. Moving to the next aspect, abdominal assessment. So this is another important stuff under the gastro system, abdominal assessment. Okay. See, there are 9 quadrants in abdomen. You know that, isn't it? So the central post portion is called as what? Center is? What's the name? What name you will give? Yes?
Umbilical.
We can give it as epigastric. Okay, epigastric. Okay. What about the sorry, center is umbilicus. Wait, why did I write epigastric? Sorry. Center is umbilicus. Right? So top of the center is epigastric. Okay. So then bottom is what? Bottom is
Hypogastric.
hypogastric. Yeah, very good. Hypogastric. So then right side top is
Right hypochondriac.
right hypochondriac. Okay, right hypochondriac. Then here
That
we
is
are
left-
having
left
left same. Okay, hypochondria. So then what's here? Next to umbilicus,
lumbar.
right lumbar. Very good. Okay, so here it is left lumbar. Okay, so then here it is. Yes, right?
Inguinal region.
Iliac. Okay? And this is left iliac. So these are the 9 quadrants of abdomen. Okay, yeah. So knowing these quadrants are important because when you get under complaints, for example, you know that when the client has gallbladder or cholecystitis, cholelithiasis and all. So under the options, if you get like the complaints in the right chondriac region, so then you can consider as yes, that is right. Because since the gallbladder is present in the right side, so of course, right hypochondriac region only the complaint will start. Not in the left region. It will be easier for you. So knowing the quadrants are important, okay, and where the organs are also, the parts are also present. Okay, so see here, this is very important in the sense. So I just want you to focus on these aspects. So especially when this one, the diverticular disease at all, left lower quadrant, remember like that. Okay, so left side, diverticulum, left side. So we will study those conditions in the Wednesday session. So ulcer, stomach ulcer and all are basically left to right. Okay, it will radiate because stomach is present in this region, isn't it? So therefore, it can go to the epigastric left side also. Fine. So kidney stones are towards the lumbar region. Okay, so kidney stones and all. And iliac region, appendicitis, hernia, inguinal hernia and all will go to the iliac region. Okay, and this point and between the right iliac crest and the umbilicus at the center there is a point. And what point is that? What point is that? Yes, in determining which condition there is a point here. What's that? Huh? McBurney's.
McBurney point.
Yeah, McBurney's point. Okay, to know the if there is tenderness in the McBurney's point, what does that indicate? Appendicitis. Okay, yeah. So now coming to the abdominal assessment, please note this IAPP. This is important. Why? Because normal under head to foot assessment, how do you do? What are the steps? You inspect, and after that, do you auscultate? In normal other, no, what you do? You?
Palpation, percussion, and auscultation.
Yes, you palpate, you percuss, and then you auscultate. This is the steps. These are the steps that you follow in the case of normal head to toe assessment, apart from abdomen. Okay, but only for abdomen, the steps are in this way. That is inspection, auscultation, palpation, percussion. Remember, sorry, palpation is last. Inspection, auscultation, percussion, and palpation. Remember these steps. For normal head to toe assessment, it is IPPA, and whereas here it is IAPP. Okay, yeah. So why? Because so if you palpate before itself, what can happen? So before percussing and auscultating, if you palpate just like here, so the option, the bowel can rupture or the distended organs can rupture. Okay, so in order to avoid those complications, we put the palpitation at the end here. Okay, so by auscultating, percussing itself, you will be knowing the severity. Okay, so that's why. So IAPP, learn what is the difference between IAPP and IPPA. Okay, yeah. So coming to the bowel sounds, knowing about the
Can
bowel,
you just explain that once more?
Which-
Since while you're doing the percussion before palpation,
percussion, sorry, I didn't get that.
ma'am, why we are doing the percussion before palpation?
So that it will not rupture. Okay, so in percussion, yeah, when you palpate, you are going deeper, isn't it? So it can rupture like appendix and all. When you palpate, you know, so it can rupture. So that's why. Okay, so we are putting the palpation at the end. Yeah, so but before it ruptures itself, so if through percussion, so you will know to you can actually identify the problems too. Okay, so that is why percussion is done. Through percussion itself, you will come to know most of the problems. So what could be the client having? Okay, or the problems. Fine. So you are actually, when you palpate, you are feeling all the changes in the organs. Okay, the structures and all, you will actually find the changes, and also it can rupture. Okay, so that's why. So mainly you are actually palpating it at the last. Okay, and when if you put the palpation before itself, so percussion results will alter. Okay, the percussion and auscultation results will alter if you palpate beforehand itself. Okay, when you auscultate, you will be auscultating for the bowel sounds. Okay, when you percuss, you will note the sound, the resonance and all, you are actually assessing. Okay, so when you palpate before doing the percussion and auscultation, so everything will get changed. Okay, so the bowel sounds will get affected, the resonance will get affected. Okay, so that is why, so we are not palpating so beforehand itself, so rather, so we are percussing first, and after that at the end palpation is done. Is that clear? Okay,
No, clear.
okay, so we'll move to the next one. So while moving now here in the bowel sounds also, usually while checking for the bowel sounds, you take the abdominal as you divide it as 4 quadrants. Okay, so you divide it as 4 quadrants. You start from right lower quadrant and it will go like that. Okay, so you start from right lower quadrant and usually it will go like that. And here, so you need to check every quadrant, you need to assess for at least 5, a minimum of 5 to 30 bowel sounds. Okay, so 5 or to 30 vowel sounds needs to be assessed. And these vowel sounds can range. It can be hypotonic also or hypertonic also. Two kinds of vowel sounds you will hear. Hypertonic or hypotonic. Okay, so hypotonicity in the sense when there is no movement of the intestine, okay, intestinal contents if it's not moving, hypotonic. Or else in which condition you will hear hypotonic. Hypotonic means very less vowel sounds. What could be the other conditions? Can you imagine?
Paralytic ileus.
Paralytic ileus. Okay, very good. Yeah, then
Post-op abdominal surgeries.
Surgeries.
the surgeries. Yes. Okay, so very good. If there is any, if there are in conditions like peritonitis, okay, the vowel sounds are reduced when intestinal movements are restricted, and also in intestinal obstruction. Intestinal obstruction in the sense, just imagine if the client is having an obstruction here. Okay, so obstruction is here, and when you auscultate here, the vowel sounds will be hyper. Okay, because the intestinal contents are trying to push or force here. They are exerting their force here, but below the obstruction, the sound will be hyper. Okay, above the obstruction, the sound will be hyper. So below the obstruction, the sound will be hyper. Okay, and gastroenteritis and diarrhea and all, what kind of sound you can experience, you can expect?
Hyper.
Hyper. Yeah, hyper. Okay, yeah, so that's about the abdominal assessment. Is that clear? Yeah. Now so these were all about the diagnostic aspects. Moving to the conditions. The first condition that we are going to discuss is GERD. Okay, GERD, or as I already told you, so gastroesophageal, this one, reflex diseases and all. So you already know these aspects. Okay, now here in this condition, as I already told you, and through the pictures also, it is very clear. So you understand that what's actually happening here. So here mainly, so the esophagus is affected here. Okay, so because of that, so the sphincter, okay, so it is this is how it has to be. It has to be closed all the time. Okay, but sometimes in reflex diseases, so it loses its elasticity. So that is what happens here. Okay, so if it loses its elasticity, so then everything, the food, the contents and all will be coming out, isn't it? So that is the problem. Now, what all could be the causes here? Causes for GERD or risk factors for GERD. Do you know what are the risk factors? Any idea about the risk factors? Yes, these are some of the risk factors. Okay, obesity, older age, because the tone will be weakened, sleep problems, NG tube insertion. Okay, ingestion of foods that will relax the sphincter, like fatty foods, fried foods, chocolates. So when too much of these foods are taken, tomatoes, citrus fruits, alcohols and all, they will be relaxing the sphincter. Okay, so they are considered as irritants. So you should think under the management. So these foods have to be avoided. So that is what you need to think. Okay, yeah. So, and also there are some medications also that will relax. Theophylline, nitrates, calcium channel blockers, anticholinergics. They are the ones that will relax the lower esophageal sphincter. Okay, and sometimes when the client is on NSAIDs and all, so there is no adequate gastric emptying. Fine. So these are the risk factors that can lead to GERD disease. Okay, so GERD, gastroesophageal reflex disorder. Yes, obesity also. We talked about that. Okay, now here the symptoms are very, very familiar with you all, like in the sense dyspepsia. Okay, so when you change your position, the pain worsens. Pain after eating, okay, like regurgitation, pain after eating, chest pain, flatus, okay, and usually when you drink water, you will find when something comes up Okay, there is heartburn, and when you drink water, you'll find that a bit of relaxation. And even when antacids are taken, you find some relaxation. Okay, so these are some of the symptoms that are associated with the GERD. Okay, so symptoms of GERD. So these are the risk factors and the symptoms, and even like the client who lies soon after eating food. Okay, what happens when you lie down soon after eating food? So the food will come up into the esophagus, and that will cause these problems, isn't it? Okay, so now what are you supposed to do now? Avoid these factors. That is the best thing that you can do. Okay, avoid factors that decrease. So all the factors whichever we discussed, like so the foods, avoiding those foods. Okay, eating low fat food, high fiber food. See here, for this condition, high fiber food is needed, so that the whatever you have taken, so that will move to the intestine. Once it moves to the intestine, then it is safe. Okay, as long it is there in the stomach, it keeps coming up. So if you eat high fiber food, what will happen? So the food will move down, isn't it? So that is what we want in order to avoid this. Okay, and not to eat anything before bedtime. So avoid, so that when you sleep, so there is nothing inside the stomach. So then you will have a peaceful sleep. So it should, like, actually before you go to bed, you need to sleep. So have your dinner before 3 hours of bed, so you can avoid with these problems. Fine. Okay, so then administration of antacids, H2 receptors, gastric acid pump inhibitors, avoiding anticholine. Anticholinergics are the ones that will slow down everything. Okay, that will delay everything. So avoid. If the client is on any anticholinergics, for many conditions, the client will be put on anticholine. For cardiac conditions, for respiratory conditions, everything the client have got certain anticholinergic drugs. So that can also cause this delaying emptying. Okay, yeah. So, and also aspirin contents have to be avoided. So this aspirin has that salicylate, that has got a sticky nature. So it can increase the symptoms. Okay, so therefore this acetyl salicylic acid also should be avoided. Fine. So these are the ways through basically how you can prevent this. Fine. So now the client, you need to note the complications of this GERD. So that's very important. Okay. So one is, so because of continuous reflux of gastric fluids, so it can get aspirated into the trachea. So because of continuous reflux, so this can get aspirated into the trachea, and that is a little dangerous. Okay, when it gets aspirated into the trachea, so then the client will have asthmatic symptoms, upper respiratory tract problem. It can also end up in what? Aspiration pneumonia. Okay, so aspiration pneumonia also can happen. So this has to be avoided. Fine. And another one is a pre-malignant condition can arise, and that is nothing but esophageal adenocarcinoma or Barrett's epithelium. Barrett's epithelium, in the sense the epithelium will turn red. Okay, so red, so in the esophagus, the tissue will change. So because, see, the gastric fluids are getting refluxed, in the sense there is continuous esophageal inflammation. Okay, so but as a compensatory mechanism, whenever there is esophageal, so whenever there is esophagitis, the body is healing. The body is trying to heal naturally, and this healing process will stimulate what, the tissues texture and all will change, and then that is something, it will become more reddened, and that normal esophageal epithelium will be replaced by a pre-malignant tissue, and that tissue is something we can call it as esophageal Barrett's epithelium. Okay, so Barrett's epithelium is nothing but a pre-malignant tissue that is developed. So during the process of replacing the normal affected esophagus is something that is called as Barrett's epithelium. So this is pre-malignant, pre-malignant tissue. Okay. Yeah, which we can call it as esophageal. This can later develop into esophageal adenocarcinoma. Okay, so this is very important. So esophageal adenocarcinoma, that is the major complication, which is nothing but the cancer of the esophagus. So that can eventually arise so later because of this GERD. So therefore treating GERD is very, very, very important in order to avoid the complications. Okay, yeah. So moving to, that was about the complications. Yeah, so hope you have understood about this. Moving to the next important condition, we are going to discuss about cirrhosis of liver. So this is a very, very, very important topic, cirrhosis of liver. So what happens here in cirrhosis? Cirrhosis in the sense the liver is getting scarred, okay, or the liver is getting inflamed. The normal liver is actually getting replaced by fibrotic tissues. Okay, it is becoming fibrosed. The normal liver tissue is replaced by fibrotic tissues. Okay, the portal circulation is affected. The liver's functioning totally gets affected. Okay, so the bile flow is getting affected. Fine. So then the new bile channels will be opened up here and there, but that will also be not that fine. Okay, so that is cirrhosis of liver. So this condition is really a life-threatening condition in the sense, cirrhosis of liver, because liver is one of the major structure, you know, major gland. Okay, so and if liver gets affected, so what happens? So totally the functions are, the entire body's functions are greatly affected there. Okay, yeah. So now let us see some of the aspects under the cirrhosis of liver. There are basically three types. One is post-necrotic, Lennox we say, biliary we say. Post-necrotic in the sense because of viral hepatitis and all, if it has occurred, you know, so that is post-necrotic. Lennox is alcohol-related liver cirrhosis. Biliary is because of any autoimmune disorders and all, so that is biliary. Okay, yeah. So now, knowing the signs and symptoms of cirrhosis of liver is very important, because so this is something easy. If you know the functions of liver, so you can understand why these problems develop. Okay, if there is any liver problem, mainly all our body parts are affected. First and foremost, neurologic system is affected. Can you tell me why neurological system is affected? Liver and nerves. So what's the role there? Brain, liver and brain. How neurological system is affected? Yes, answers?
Collection of ammonia.
Very good. Ammonia. What is this ammonia? Where it is found? Yes. Ammonia. Ammonia is usually present in our body, and that we generally what we can say, like ammonia is present in basically it is used as a fertilizer, isn't it? So in crops and in plants and all, it's basically used. And ammonia mostly when in deep freezers and all, ammonia gases are there. So what happens, the food that we consume naturally will have ammonia. So when it is used as fertilizer and all, so definitely, so we generally intake that ammonia also, isn't it? So now, so this ammonia has to be in a normal person. We don't need to worry so much. Why? Because the liver plays a major role in removing the ammonia. It will detoxify ammonia. Okay. So whereas when liver itself gets affected, so the detoxification doesn't happen. Rather, the ammonia will cross the blood-brain barrier and it will start depositing in the brain, causing neurological problems, peripheral neuropathy, where the tingling sensation in the nerves and all you will actually be seeing. Okay, so then asterixis is for flapping motion like this. Again, this flapping motion is something we can call it as asterixis. So you will be finding that. Okay, so and all these problems arise. The neurological problem basically arise because of the inability to detoxify ammonia. Fine. So therefore, we give what you know. So we give a drug called as lactulose, that is a laxative. Okay, lactulose. Let me write here lactulose. So this lactulose, what it will do? It will remove the excess ammonia from the body. Lactulose is given in order to bring changes in the nervous system. Okay, so neurological system. So apart from that, you can see here when we come to the integumentary system also, finding purpura, petechiae. What are these? What do they indicate? Purpura, I keep saying, right? Purpura, petechiae and all are the indications of what problem? Tell me. What problem? Coagulation problem.
Bleeding.
Yes. Okay, coagulation problem. Now, liver is the main gland that is responsible for producing the clotting factors. Okay, so clotting factors are produced in the liver. So now if liver has any problems, so then there will be coagulation problem. That is manifested as purpura in the body, and all you will be finding reddish spots, purplish kind of spots. So that indicates there is some problem with the liver. Okay, spider angiomas, all the blood vessels will be affected. You can see like these marks and all. So they are nothing but show the problems. They are the integumentary symptoms of cirrhosis of liver. Okay, gastrointestinal. As you know, liver's role major is in metabolizing fats, carbohydrates and all. And if that doesn't occur normally, indigestion, anorexia, bowel habits change, bad smell. Okay, so gastric varices also will develop. What is this gastric varices? Any idea? Esophageal or gastric varices? This is a complication of cirrhosis of liver. Esophageal varices, gastric varices is a complication of cirrhosis of liver. Do you know what happens here in varices? I will show you the picture of the same. So you can see here. Sorry, somebody's talking.
Dilation of veins.
Yeah, dilation of veins in the sense how it is getting dilated.
Portal hypertension.
Portal hypertension. Yes, here the liver is getting scarred, isn't it? So now it is getting fibrosed. So now what will happen? So the circulation inside, the portal pressure is actually rising because of this scar tissue. So what it will do? Through the collateral pathways. So next to the liver itself, the esophagus will start. Okay. So through the collateral pathways, it will exert pressure into the next blood vessels also that is present in the esophagus and all. So because of this, the esophagus, the exerting pressure from the portal veins will dilate the veins in the esophagus, causing esophageal varices. This is a dangerous condition if it is not treated properly, you know, so then it will rupture and bleeding can occur. Okay, so esophageal varices is a complication that arises because of cirrhosis of liver. Do you understand? So these are the that is one way through which the gastric varices generally happen. Okay, gastric or esophagus, the reasons are the same. Okay, hematemesis, blood vomiting, gastritis. Okay, so these are the gastro problems. Hematologic problems. So we know liver is responsible for producing, storing RBCs. Okay, and anemia, thrombocytopenia, because there are no platelets. Platelets production goes low. WBCs goes low. Okay, coagulation disorders will occur. Spleen will start accumulating fluids. Splenomegaly, hepatomegaly. Okay, the fluids are so here the functioning of these organs also gets affected here. Let me also say another the main electrolyte changes that happens here. This is very, very, very important. Okay, electrolyte changes. So electrolyte changes in the sense you need to understand mainly these three electrolyte changes you need to remember. One is potassium deficiency, another one is hyponatremia, and the third one is hypoalbuminemia. Please learn this. Why do they occur? Why do they occur? Knowing that is very important here. Okay, so now in our body, so there is a kind of osmotic pressure maintained, which we can call it as oncotic pressure. Okay, so oncotic pressure is nothing but the pressure that is there within our body, and because of which the cells in the water inside the cells are actually held. Okay, so there is a pressure inside our body which we call it as oncotic pressure. Okay, it is a kind of osmotic pressure, and because of this oncotic pressure, the fluids in our body are held. It is not coming out, it is not leaking. The moment the oncotic pressure goes down, the fluid starts leaking. Okay, now here the plasma proteins play a major role, which is nothing. The plasma proteins are albumin. Albumin is made by the liver. So albumin has to be there to hold or to maintain the oncotic pressure. Okay, so if albumin is not there, so what will happen? The oncotic pressure will go down. When oncotic pressure goes down, the fluid inside the cells and all starts leaking, and they leak, and that is why in cirrhosis of liver there is edema. This gets accumulated in the extracellular component. They leak and accumulate in the peritoneal cavity, causing ascites. Do you understand? So that is why hypoalbuminemia is one of the causes. I mean, so everything, the fluid leaks. Okay, and this will cause edema in the entire body. So edema occurs because of hypoalbuminemia. Hypoalbuminemia occurs because of the liver problem itself. Okay, only if liver is there, albumin can get produced. If albumin produces, only the water in the cells are held properly. If water is not held properly, so then water will start leaking, and then it will cause edema, peritoneal, this one. Ascites and all. Do you understand? So that's why hypoalbuminemia is one such reason for these edema and all, and you know why hypoalbuminemia occurs also. Coming to the next, hyponatremia, you would have learned that. So whenever there is water intoxication in the sense more amount of water accumulated in the extracellular space. Now I told you, when oncotic pressure goes down, water starts leaking, and all this water will get accumulated in the extracellular space, causing edema. Whenever there is edema, the sodium level will go down because the sodium will get diluted there. So because sodium itself is an extracellular component. Okay, so that is why hyponatremia occurs. And also potassium deficiency occurs. So this is because of the increased action of aldosterone. Aldosterone. Do you know what is this aldosterone? Aldosterone is the hormone that is produced in the adrenal glands. Okay, adrenal glands are the two small glands that are located on top of the kidneys. They produce aldosterone, which is very important for the mineral balance, water balance of our body. Okay, aldosterone. Generally, what does aldosterone do? Aldosterone retains sodium water. Okay, aldosterone retains sodium water and it excretes potassium from the body. It removes potassium from the body. Is that clear? Okay, you should understand all these things. Okay, you may find little confusing here and there. I'm going very slow to make you understand these important concepts. I don't want you to go without understanding why these aspects happen in cirrhosis of liver. Okay, so please understand that aldosterone is a hormone that is produced in the adrenal glands of the body. Okay, so these aldosterone, if it has to function, the liver should be normal. Okay, liver is the main commander for aldosterone also. Okay, so now when liver is affected, aldosterone will get abnormally stimulated. And what it will do, it will retain more and more sodium water, and at the same time it will remove potassium from the body. Aldosterone's normal function is to retain sodium water, remove potassium. When it gets abnormally stimulated because of the problem in the liver, it will store more water, and it will remove more potassium from the body. And that's why there is potassium deficiency. Okay, so did you understand why these three metabolic changes occur in cirrhosis of liver? So was that clear? Yes. So was that clear? I just like to get your clarification.
Yes, ma'am. Yes, ma'am.
Yeah, okay. Moving to the next. Of course, so because of the changes in these aspects, cardiovascular system also, you know that, like because of edema and also there is fluid retention, how these basically affects. Okay, and similar effect is on the sex hormones also. When liver is affected, sex hormones are also getting affected, causing amenorrhea, testicular atrophy, gynecomastia, impotence and all. Okay, so these are, see, if there is cirrhosis of liver, see, in every individual this may not be the problem, so each person it will differ. Okay, so everyone, every person, all these symptoms will not occur. For one, if the GI problems are there, for other integumentary. Depends on the severity of the liver damage. Okay, and but in many of them, so this ascites is a common problem that you can see. Okay, yeah. Now, how to manage the cirrhosis of liver? Cirrhosis of liver management is mainly symptomatic. Based on the symptoms, the management is done. Okay, like if there is a edema, diuretics are started. If ammonia is too high, we should avoid protein, because ammonia is a derivative of protein also. So if ammonia is too high, you should avoid protein. Likewise, okay, so depending upon the problems, you need to focus on the interventions, like checking vital signs are important. Pain can be there, you can give analgesics. Neurological status monitoring is needed. Okay, lactulose are given if neurological status are deteriorating. Check for ascites. Measure the abdominal girth daily. So this is very important. Okay, so check for nutritional status. See here, nutritional status I have mentioned here as high protein. This is because if the client is having edema and all, high protein, because albumin is hypoalbuminemia, we need to give high protein, isn't it? But if the client is having ammonia related neurological problems, you don't give high protein. Okay, low protein. You should know the question how it comes based on that. Okay, so when you get questions on neurological, if the client has high levels of ammonia, the diet, don't select high protein thinking that, so in the class high protein diet was discussed. No, that's wrong. In the class, high protein diet is discussed if the client does not have any neurological problems. Remember. Okay, so high protein diet we should give for basically when the neurological system, when it is not affected, and as well as when the client is having edema and all. So then only high protein is given. Okay, so and the respiratory status you need to mention everything. Okay, fluid monitoring, intake output, weight monitoring, weight checking. Okay, and these are all the essential education points. Also health education is also, so you need to focus. Yes, here I have noted here, please note this point, low protein if encephalopathy or elevated ammonia. So this point is important. Okay, yeah. So then fluid restrictions, so depending upon edema, okay, and diuretics, lactulose, antibiotics and all are actually given here based on the conditions. Okay, so is that clear? Was that clear? That's about cirrhosis of liver. Okay, so and this management. Yeah, so now let us do a few questions on this. Can I ask someone to read? Yes, Archana.
The nurse is caring for a client with cirrhosis who has hepatic encephalopathy. The client is prescribed lactulose, which assessment by the nurse will most likely indicate that the medication has achieved the.
Yeah. Others can give your answers in the chat box.
Second one, ma'am.
Second one, improved mental status. Any other answers? You know, all are given, all are, yeah, giving the right answers. Very good, very good. Okay, so second, improved mental status is the right answer. Okay, that was easy, isn't it? See, lactulose is a laxative. Remember, lactulose is a laxative. So when lactulose is given, the client will experience this one, diarrhea. Loser stool consistency will be there. Whereas the question focuses on So which assessment by the nurse will most likely indicate the medication has achieved the therapeutic effect? Therapeutic effect in the sense the purpose why the medicine is given, whether that is achieved or not. So that is through improved mental status. Okay, very good. Okay, now the nurse prepares to administer IV albumin to a client with severe liver disease who has low serum albumin. Which characteristic finding associated with hypoalbuminemia should the nurse anticipate assessing? Characteristics.
Pitting edema.
Pitting edema?
Fourth one, ma'am.
Yes, pitting
Yes, ma'am.
edema is the right answer. Very good. Easy. Fine. So now you know like why there is reason of pruritus in cirrhosis, isn't it? So pruritus, why does it occur? Tell me. What's the reason? Pruritus means itching on the skin.
Bilirubin.
Coil.
Bile, yeah, exactly. See, the bile salts are more here. See, usually you know the normal process. The RBCs, lyse, the bilirubin has to get converted as bile juice by the liver. Okay, so now here what's happening? The bile salts are accumulating because the liver is non-functional. So now the bile has to come out, however. So it will try to come out. It has to be removed from the body, isn't it? So the bilirubin level is more and more and more. It will try to come out through the skin. And the bile salts will be accumulated on the skin, causing itching and all. Okay, so this is the same thing you will find in kidney failure conditions also. When more metabolic wastes are accumulated in the body, when the kidney doesn't filter enough, you know, so they have dry skin, itching, and lots of itching. The same thing here also. Okay, the waste because of the bile salts accumulation here. So and the bile tries to be come out through the skin, causing pruritus and all. Now, what are the ways through which you can promote the skin comfort and skin integrity? Cool, moist, wash clothes. Yes, right answer. Very good. Keep fingernails trimmed short to minimize
Yes,
scratching.
ma'am.
Yes. Hot shower bath. Is it helping?
No, ma'am.
No, ma'am.
No.
No hot shower. Okay. Hot shower. Extremes of temperature should be avoided. You can advise the client to take bath in warm water, lukewarm water, not hot water. Skin protectant or moisturizing over the unbroken skin.
Yes.
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 Cotton gloves or long sleeved clothing to avoid
Yes.
scratch.
Yes.
Yes, this
Yes,
also.
ma'am.
So 1, 2, 4, and 5 are the right answers. Okay. Moving to the next one. Okay, here it is. Okay. A patient with late stage cirrhosis develops portal hypertension. Which of the following options below are complications that can develop from this condition? Give your answers. C and E.
Second one, ascites. E, esophageal varices, and
Okay.
C also.
Very good. So the albumin levels will be low, right? So A is not the answer. B, C, and E are the answer. Fluid volume is more, excess, not deficit. So these are B, C, and E are the answers. Okay. During your morning assessment of a patient with cirrhosis, you note the patient is disoriented to person and place. In addition, while assessing the upper extremities, the patient's hands demonstrate a flapping motion. This is a very easy question. What lab
C1,
result?
ma'am.
Yeah, C1. isn't it? Yeah, very good. Moving to the next one. You are receiving, I want all of you to try this. Okay, so you are receiving shift report on a patient with cirrhosis. The nurse tells you the patient's bilirubin levels are very high. Based on this, what assessment findings may you expect to find during your head-to-toe assessment? What you will find?
C.
Only C, E?
E.
What about the urine color? When bilirubin levels are high, how is the urine color?
Dark.
How's it? Dark.
V.
Okay, this you cannot select. Whereas this you can select. B you can select. Okay, so urine color will be dark. Why? Because bilirubin is there in the blood. Kidneys have to filter blood. So when blood comes to the kidneys, what will happen? So the bile salts are trying to be filtered out, and therefore the urine color is dark brown. Fine. So what about the second one, the third one? Yellowing of sclera?
Yes.
Yes.
Yes, ma'am.
Dark brown stools?
No.
No, ma'am.
Okay,
It's
no,
clear
dark brown stool is normal. In normal people it is. When
Yes,
bile
ma'am.
salts are high, so there will be clay colored stools.
Clay colored.
Clay colored stool.
Jaundice is present. Mucous membranes? No.
No, ma'am.
Yeah.
No.
So B, C, and E are the right answers. Okay, moving to the next one. You are providing an in-service to new nurse graduates about esophageal varices in patients with cirrhosis. You ask the graduates to list activities that should be avoided by a patient. So cirrhosis, see, esophageal varices, remember the veins are dilated. So you should avoid it from rupturing.
Ma'am,
What are
first
the
one. Fourth
excess
one.
coughing should be avoided. Yes, very good. Because when you cough, you know, that can rupture. Fine. So you remember the picture that I had showed, isn't it? So that will rupture. So you can see there. So when it becomes more in the sense like cirrhosis of liver and all. So what's actually happening? The esophageal varices. What's actually happening? Okay. So here you can see here that the veins are getting dilated. Okay, it's exerting too much of pressure. And if it pressure is more, so then easily it will get open, rupture. Okay, so that is what happens here. So therefore, so this thing you need to make sure. Apart from that, what about sleeping on the back? Is it needed for cirrhosis of this one, esophageal varices management, sleeping on the back?
No.
No. Okay, see, somebody had asked me about SATA. Just think whether each option is related to the question that they have asked. What activities are correct for esophageal varices? Sleeping on back, that's okay. Okay, so I mean, yeah, so in the sense, what activities are avoided? So that is asked here for esophageal varices. Sleeping on the back, that's okay. So I mean, so no need to select. Drinking juice? Drinking?
No.
No. Alcohol consumption?
Yes. Yes.
Right. Yes, ma'am.
Okay. Yes. Then straining during a bowel movement?
Yes, ma'am.
Yes. If you strain, it will rupture. Vomiting?
Yes.
Yes, ma'am.
Vomiting is also yes. Okay. So A, D, E, and F are the right answers. Okay. After dinner time, during early rounding, a patient awakes to report they feel like food is coming up in the back of their throat and that there is bitter taste in the mouth. What nursing intervention will you perform next is the question. Perform deep suctioning, semi-Fowler's position, keep the patient NPO, instruct the patient to avoid milk products.
B.
Semi
Second
Fowler's.
one.
P. B.
B, isn't it? See here,
Yes.
very good. So now this is during the night, after dinner time, in the sense night hourly rounding, the patient is telling like that. So what's the next action? Next action is to make the client to sit up. Okay, so therefore through which the symptoms can be reduced. This is a good question. Okay, good. Okay, the next one. The nurse is preparing a client diagnosed with GERD for discharge following esophageal gastroduodenoscopy. Which statement indicates the client understands the discharge instructions? I should not eat for at least 1 day following this procedure. Do you think so? After GERD, after esophageal duodenoscopy, are you not supposed to
No,
eat?
ma'am.
That's normal, isn't it? I can lie down whenever I want after a meal. It won't make a difference.
No.
No,
No.
ma'am.
He can't. Can he lie?
Yes.
No.
Yes.
No. He cannot.
Okay. The stomach contents won't bother my esophagus, but will make me nauseous.
No, ma'am.
No.
You can't say like that. I should avoid orange juice and eating tomatoes.
Yes.
Yes. Why? Tell me.
Yes.
Because citrus. Okay.
Citrus.
Yes, true. So therefore, so this is yes. Option D is the right answer. Right? Okay. Okay, this is fine. The next one. This is easy. Next one. A client with suspected gastric cancer undergoes an endoscopy of the stomach. Which of the following assessments made after the procedure would indicate the development of a potential complication? After endoscopy and all, what did I say you have to consider?
C, miss.
C, ma'am.
Freeze in temperature, isn't it? So that indicates what? Bowel perforation.
Perforation.
Okay? Therefore, option C is the right answer. A patient has hypoactive bowel sounds. The nurse knows that a potential cause of hypoactive bowel sounds are what?
B.
B.
Peritonitis.
Fourth one.
B.
Peritonitis, isn't it? Yeah, peritonitis is the right answer. Okay. Yeah. So very good. Okay. So diarrhea, laxative use, gastroenteritis, and all will be increasing the bowel sounds. Hyperactive bowel sounds are heard. Okay. So whereas these indicate peritonitis indicate what? Hypoactive bowel sounds. Okay. Yeah. So these were some topics we had to discuss today, and let me also explain you some of the, see here in esophageal varices, the assessment findings you need to know. There is hematemesis, melena, black stools, tarry stools, ascites, jaundice. These all are found even in esophageal varices. Okay, you should be avoiding all these training procedures. So that's the main focus, is to make sure that it doesn't get ruptured. Okay, so that's very important under the esophageal varices. And there are different ways through which this is treated, in the sense like we have like there are some banding procedures, binding. Okay, sclero I mean, so yes, sclerotherapy. Okay, so that is one procedure, fine. And also you are having different other procedure like this one, balloon tamponade, through which balloon, the inflated balloon will actually be compressing, and thereby it will the bleeding will be avoided, okay, or it will be stopped. So likewise, many procedures are there in esophageal varices. Procedures are not that important for us. You need to focus on the ways how to manage these conditions. Okay, you need to monitor for bleeding, and you need to this can be, you can't always, sometimes every time the client there may be no hematemesis and all. So therefore, in that case, you need to keep checking for the hemoglobin hematocrit levels. If it is going down, so then that indicates the client is having some bleeding is happening with it. Okay, so that is why these aspects have to be monitored very frequently for cirrhosis of liver, esophageal varices and all. Is that clear? Okay, yeah. So now that was all about today's discussion. So do you have any doubts or clarifications based on today's topic?
Yes, ma'am. I have one question.
Yeah.
Ma'am, what is the difference between direct and indirect levels of bilirubin?
Yeah, so direct in the sense which is directly released into the in the sense, see, bilirubin basically we are having the total bilirubin count we will be taking, so that is the one thing. Okay, so and also we take, like, there is two kinds when under the basically in the laboratory values also you will be finding direct and indirect. Okay, so isn't it? So direct in the sense, so mainly direct bilirubin is also called as conjugated form of bilirubin. Okay, so which means that, so that is usually conjugated in the sense it is taken by the liver and then it is actually released. So that is why we call it as conjugated. Like, I mean, the bilirubin has reached the liver and then the changes have happened in the sense it has been converted into bile juice and all. So that is something, the changes has happened in the liver. So that is conjugated liver or conjugated bilirubin or direct bilirubin we say. Okay, so unconjugated in the sense or indirect bilirubin in the sense which has not reached the liver yet. Okay, and the changes has not undergone in that bilirubin, and that is called as unconjugated or indirect bilirubin. Okay, is that clear?
Okay, thank you, ma'am. Yes, ma'am. Thank you.
I have a question, ma'am.
Yeah.
For the esophageal varices, if it ruptured, ma'am, what will be the complication and the next
Shock.
treatment? Shock. And then the treatment will be as per the symptom of shock?
There will be, I mean, so shock is the major complication. Before that, you need hypervolemia will be there. Okay, that will end up in shock.
Okay, thank you, ma'am.
Yeah, fine. So anything else? Hypovolemia, sorry. Okay, the blood level will go down. So hypovolemia. Yeah, anything else? So if everything is clear, shall we wind up today's session? Yeah, so in the next session, I would be explaining the remaining aspects of gastro topics. See, I mean, so specifically today, so we have discussed about the cirrhosis, so and all, you know, you to do the same questions and take Lippincott book for finding the specific topic related questions. Okay, Lippincott's book manual is there in your canvas under resources, isn't it? Open that. You will be finding specific questions related to the topics that we are discussing. Okay, so and you can do those questions. In general, if you want to finish the questions, you can first finish from Saunders and also the canvas assignments, whatever is there, you know. So once we finish discussing everything, you can open that and also do the questions, but keep practicing questions. So that's very, very important. Okay, yes. So, and those who are having any doubts, so please let me know via Teams. So I'll reply to your messages. I'll clarify your doubts. Okay, so whatever doubts you are having, I would be clarifying related to the academic aspects. Okay, for technical queries and all, so you can contact Nimmi as well as Praveena. Okay, so see you then. Take care. Bye.
Thank you, ma'am.